Okay, well, why don't we kick it off? Good morning. Happy Thursday. Thank you so much for being here today. My name is Leslie Carty, and with Dr. Ray Markham, I co-lead the Rural Coordination Center of BC. I'm so thrilled to be able to be with you this morning, opening up the BC Rural Health Research Exchange. I'm calling in today from our Coastal Node office of the RCCBC, which is on the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations, as well as the Kiakiat, Semiahmoo, Tawasin, Kwantlen, and Stolo. I live on Squamish and Tsleil-Waututh land, also over known as North Vancouver, across the bridge, and have been spending some time really reflecting and getting to know certainly the community of the Tsleil-Waututh, the people of the River's Inlet better as I share and live on their land. If you would like, please feel free to pop in the chat where you're calling in from today and where you're joining. So I want to welcome you to the 5th BC Rural Health Research Exchange. 5, it feels like a big number. That's really exciting. And the intention of this virtual event is to share research that's happening around BC and to do it in a really accessible way. With the exception of the keynote, the presentations, they're going to be rapid fire style. We've got about 10 minutes for the presentations and 5 minutes for Q&A questions. Questions can be added to the chat box. So if something comes up for you during one of the presentations, please throw it in the chat box. We have a total of 16 presentations from across the province this year. We have physicians to pharmacists, to academics, to students, we have patient partners, and because we want to just make it really simple and clean, this year we have one Zoom room. So you don't have to toggle between 2 links, which we've done previously. So everyone's in one place right here on this Zoom channel. So if you need to pop off, you know exactly where to come back to. You don't have to look at the schedule, and we'll continue on this same link today. I want to have a very special thanks to our presentation moderators. We have Dr. Frank Schurmeyer from the UBC Department of Emergency Medicine and Dr. Brenna Lynn, who's the Associate Dean of UBC's Continuing Professional Development. So thank you both so much. A little about RCCBC, supported through the Joint Standing Committee of Rural Issues. The why of RCCBC is to improve the health of rural patients and communities, and we bring a rural physician perspective to that lens. 5 years ago, Jason and Tracy came up with this idea of how do we share, and what year is it? Was it COVID, Tracy, when we did this, or pre-COVID?
2020.
Oh, okay. So, I mean, none of us were leaving our house in 2020, but we're thinking, how can we share across the province? There's so much happening. How can we share across the province some of the amazing research that's happening in rural and really focus on that rural research? So we were so happy to be able to support Jason and Tracy to do this amazing work. Research is a part of what we do at RCCBC, and we're thrilled to be able to support it. So next, I'd love to introduce our keynote speakers. We have Dr. Jude Cornelsen. She's an associate professor with the Department of Family Practice at UBC and is the co-director of the Center for Rural Health Research. Dr. Cornelsen is joined by rural patient partner and Princeton, BC resident, Christina Dirksen Unruh. And together, this dynamic duo will present on housing is healthcare, equity and access for all residents. And they're going to share recent findings from a mixed method study that attempts to understand and document the consequences to and experiences of transplant patients who had to relocate to Vancouver from outside of their lower mainland to receive transplant care. So I'm going to hand over to them. And in the meantime, you can message Tracy or Jason if you have any quick questions on the side, but I'm thrilled to hand over to Jude and Christina.
Great. Thanks so much, Leslie. We are really, really happy to be here. I'm just going to share my slides. You've already said that we're presenting some recently recent data from British Columbia that we derived on the experiences of patients traveling to access transplant care in the Lower Mainland. what we're going to try and do today is three things, and foremost among them is understand the rural experience of the rural patient experience of coming into Vancouver for transplant care. And so my esteemed friend and colleague Christine is going to be focusing on that in just a minute. I think that this is going to provide a really important contextual framework for actually understanding the data on costs and experiences. But, before we jump into it, or before I turn over to Christina, I do want to note my personal involvement in the topic. As it turns out, while we were gathering the data in the spring and the summer, my brother, who lives in Penticton and would be very displeased to know that his picture is on the screen, although I did check it out with him, was actually put on the wait list for a double lung transplant as I was collecting data. So at the beginning of August, he got a call and within 3 hours was down at VGH and had a very successful surgery. So I'm saying this because I've got a very upfront frame of reference about these data, and it was the first time in my professional career of over 25 years that the lived experience for me has coincided so directly with what I was studying, but definitely felt immersed in what it's like to find accommodation from someone from out of town, to apply for system level funding, to help relocate, to find people to look after things back home and coax someone to stay for the duration of the recovery period when all he wanted to do was get back home. So this makes this topic really special to me, and I'm delighted to present. But right now, I'm going to turn it over without further ado to Christina, who's going to be talking about starting us off in a good way by grounding our discussion in her experience of care. And so she'll be interspersed throughout the presentation with this starting block. And over to you, Christina.
Good morning, everyone. Thank you for having me. First and foremost, I would like to thank my donors family. Without that, I wouldn't be here. It's an extremely hard journey. It's the hardest thing I've ever done in my life. And the stress is insurmountable at times where you don't know how you're going to do it, let alone trying to heal at the same time because of the costs that are just astronomical. Through the kindness of strangers, I was able to have my transplant. But I didn't have the funding in place to do it myself. And when I first went on the list, my husband and I had to make the decision to go public and start a GoFundMe because we just didn't have the $25,000 at that point that the transplant team required us to prove that we had in order to save my life. I was on the list for just over a year, and then the transplant team changed the amount that I needed to have and bumped it to $35,000. I didn't have $35,000. I had $25,000 like they asked me for a year before. So I had to take myself off the list. That's a scary thing because I went so far as to write my own obituary, write letters to my kids, my grandkids, my best friends, my husband, because I didn't know if I was going to be able to ever get back on the list. And again, through the gracious support of strangers, I was able to go back on the list May 1st. I got my first call on May 4th, and it ended up not being a good fit. So we had to come home and wait for another call. I waited for another 6 weeks and then got the call on June 23rd. So we jumped in the truck and away we went. And we got to Vancouver the next morning. I went in for my surgery. I coded 3 times on the table. But I made it through. I was brought out of surgery. I was kept in a coma for 4 days. Meanwhile, my husband, who had zero notice to try and find a place, is trying to find somewhere to stay while he doesn't know if his wife's going to live. He found a place that for the first 10 days, while he's sitting by my bedside, hoping that I survive, for the first 10 days cost $4,000 just to keep a roof over his head. It's the reality of it's last minute. People can charge you whatever they want to charge you because they know you don't have a choice. When all was said and done, by the time we came home, and I came home early, very early, because I came home at just shy of 4 months, the costs just for the 4 months we were down there was $36,000 for rent, food, parking, transportation back and forth. And in the midst of all of it, my mother-in-law passed away. So my husband needed to be here with his family. So we had to have people come and stay with me because I wasn't allowed to be alone. Luckily, we have wonderful friends that were able to drop everything and come and stay with me. But it's the stress of the funds that is just, it's a stress that when you're fighting for your life, you shouldn't have to deal with. And even though I'm home now and I'm doing fantastic and I'm so blessed, that stress is still there because before we even went into the transplant, 2 years prior for all your testing and things, none of it can be done in Princeton. I had to go to Kelowna repeatedly. I had to go to Penticton repeatedly. I had to go to Vancouver repeatedly. And just those costs for all the pre-testing was $13,000. So before the transplant even happened, we were already $13,000 in debt. My husband is the only income in our family. He had to sign a contract to be my 24/7 caregiver from the moment I got the call until I came back home. So we didn't have that income. We had to try and survive on EI, which if anybody knows, EI is not very much. Plus, we still had to maintain our home, bills at home, mortgage at home. We had wonderful friends that stepped up and took shifts staying in our home, looking after our dogs, because my dogs are the only thing that have kept me from losing my sanity over the last 2.5 years, because I haven't been able to leave my house. I couldn't walk 20 feet. I couldn't go to the grocery store. I couldn't do anything. I was basically an invalid. So through support and love and care of friends and some family, we managed to make it through. But we're still sitting here on the end of it where, yes, I have new lungs. Yes, I have a new lease on life. I'm able to play with my grandchildren. I'm able to take my dogs for a walk. I'm able to clean my own house. I'm able to go get groceries. That was my turning moment. The first time I could go and get groceries by myself was just amazing. But then the reality hits every time you sit down to figure out, okay, which Peter are you going to rob to pay Paul? Because we're still in debt at this end of it. And it's scary. It's overwhelming. Yes, I'm alive. I have a second chance at life. But there's things hanging over us now because of the cost of everything that could change our future forever. And it's a stress that really should not be put on patients and their families while they're just trying to live and just trying to enjoy life and get back to some sort of normal life. I mean, I would love to be able to one day go back to work so that I can be a tax-paying citizen again, because I was a tax-paying citizen from the time I was 13 until October of 2018 when I got sick with cancer. And to not be able to work was so detrimental to my mental health. But at the same time, fighting to take a breath every day compounded the feeling of failure and fear and thinking I was going to die. And for the last month and a half before I got my call, I literally went to bed every night stressing about, should I do this because of the stress of the finances this is going to leave my husband with? I actually thought about not doing it because I didn't want to put that financial stress on him. I never told him that. I've told him that now, but at the time, I didn't want to put that stress on him, but at the same time, I wanted to live. So my choice was put us into debt and almost crisis mode to try and move forward and live, or just sit back and let nature take its course. Ultimately, I decided I was not ready to go and I was going to fight. And I fought back, and here I am. And I'm going to do everything I can to make sure that not one more person dies simply because of not having the money. Because in the last 8 months, I know personally of 4 people that have passed away because they didn't have the money. And that's wrong. Nobody's life should have a price tag on it. We all deserve to live. Thank you.
Thank you so much, Christina. The context, as you can see, is really important. And I just want to emphasize that the costs that Christina is talking about are the relocation costs. So we're going to get into that now, what they are. They're not MSP costs. They're costs just to relocate from a rural community to get access to transplant care, which can only be done in the Lower Mainland in Vancouver. So one of the context for this study is part of a growing evidence base on cost consequences in general for patients who need to relocate from their rural communities for healthcare. So this occurs anytime subspecialist care is needed, and for smaller communities, actually anytime specialist care is needed, due to the necessity of having to stay in Vancouver at least 3 months post-surgery for most patients after a transplant. Of course, the relocation costs for transplant patients are the most pronounced of all the disease states that we've studied. We did a survey. So we did 2 things. We did a pan-provincial survey, and then we did interviews. And the survey basically looked at the relocation experiences of participants. Now, we had 2 groups of participants, those who had some means to relocate, including family or friends, excuse me, in the Lower Mainland, and those without such means. So they had no safety net going to Vancouver. It was only a minority of respondents, about 5%, had somebody that they could stay with. So we're going to be focusing on the people who did not have any support going to Vancouver. So we looked at the costs by category, and I'm just going to whip through to the price tag here. The range was significant. People spent anywhere from about $3,000 to $130,000. On average, out-of-pocket costs were about $18,000. We're still testing that with people who have gone through. As you heard from Christina, hers was much more. Some people have less cost depending on the kind of accommodation they can find. But what we did with the data is we removed outliers, the far outliers, like the $130,000 was rare. So we removed those and we came up with the 18,000. But even the lower end of the scale, people reported significant barriers and enduring hardships, as Christina has mentioned, for others who had to pay these costs. So the interviews were a really important part of this. We wanted to capture the lived and living experiences of transplant patients who are required to relocate. I'm going to quickly summarize. I'm not going to go to all of the data in the benefit of time here. But we're going to start by looking at the financial burden. So we gained an understanding of the financial burden, specifically the funds needed to relocate, which, as we heard from Chris, was not, there was not available to everybody. Not everybody had funds to relocate, and the stress it incurred. So we've got the people here. Oops, I want to go back and emphasize that only 50%, I should say 50% of the respondents reported a higher unsustainable level of stress, as Chris just described, trying to secure accommodation. More than half had unsustainable stress trying to plan travel. And we have to remember that some people are traveling in inclement weather months. And people responded, over 60% responded unsustainable stress, trying to arrange a caregiver. As Christina mentioned, you have to have a caregiver in your post recovery period. So for 3 months, you need someone with you all the time. And that was difficult for people, either because their partner, family, spouse, friends were working, or they didn't have anybody in their close orbit who could come to Vancouver, etc. So all of these things compile to make it a very stressful situation for people. It was a double whammy for patients who relied on their spouse, as Christina did, as their primary care provider, that because that required a loss of family income for those still working. And this was the case for about 65% of respondents. This led to the observation for most participants that there's a two-tiered healthcare system that disadvantages rural patients in this instance. So housing and accommodation was, of course, the biggest challenge for respondents who replied to the survey. The cost, availability, unpredictability of timing. So although financial demands for some patients undergoing transplant included having a contingency fund where they saved money because they knew they were going to have a transplant, they still had to, it was still egregious. It was still very difficult for almost all participants. They had to maintain housing in their own communities. They had to pay for incidentals in Vancouver. To drill a bit deeper in the overall challenges of accommodation, we looked at things like seasonal variation. So the summer months, if you had called for a transplant, was worse because of its tourist season, of course. People were telling us they were looking at $3,000, $4,000 a month if they were lucky for an apartment for 3 months, and it was daunting for most. A few people considered moving their mobile homes to Vancouver, not ideal for your recovery period, but that's what they felt that they could afford. I was thinking, heaven forbid, if somebody is called for a transplant during the Taylor Swift concert, it's just not going to work. The designation of medical housing that some hotels offer provided, we heard from participants, provided only marginal reductions. And many establishments on the list that say they provide medical housing actually no longer do it anymore. So there is subsidized accommodation at places like Hart House or Easter Seals, but generally, not always, but generally the demand outweighs the supply. And it's still difficult. You still have overhead costs for some. One of the biggest challenges, as we've already mentioned, in securing accommodation is not knowing when you're going to come. When you get the call, you've got 5 to 6 hours to get to the Lower Mainland, to get to Vancouver, and to find accommodation for your caregiver as you go into the hospital. A lot of people resorted to GoFundMe pages. Or one person said, I remember this quote, I'll remember it forever. I mortgaged myself to the Hilton, maxed out all my credit cards, which of course has consequences post procedure. So this led to participants observing some of the following things. I'm going to keep going here. I'm going to skip over some of the findings on patient experience and patient journey, not to minimize them. They're very, very important. But in the efforts of time here, because I want to talk a little bit about observations of stress and coping that are pretty much an impact of uncertainty of timing of procedure and where they're going to stay. So the sense of uncertainty evoked by being on the transplant list or the wait list and the procedure journey to recovery understandably led to a lot of mental health concerns and challenges for participants that were in our study, both in the survey and in the interview portion. And it was probably most acute for participants who experienced a dry run, as Christina did, down to Vancouver. So you're called for your transplant, you get to Vancouver and you find that the organs are unsustainable for whatever reason. They're not the organs are not viable. So the surgery is canceled. It led to a lot of dismay in participants and being, describing, aside from the cost and the inconvenience of travel, emotionally just being a mess due to the perception that their chance at life was revoked. Others expressed a lot of concern about the weight of the post-transplant path following, with conflicting feelings of really extreme gratitude for their life-saving surgery, while also having trouble navigating the financial and I guess health consequences of the challenges that arrived from their surgery. So Christina, I don't know if you want to finish the story of your transplant or if you did it all up front now before we go into the recommendations.
I would just want to say that, yes, it was the chance of a lifetime. It was an extremely hard journey. And I can be honest by saying now, if I'd have known all that was involved in getting through this, I probably wouldn't have done it. So I'm glad I didn't know everything, because now sitting here looking back, it's like, okay, yes, it was worth it. but it's still very scary, even though I'm doing extremely well. My medications are all managed. There's still the residual effects of the finances, and it weighs on me every single day. But that's partly why I've taken it to heart that I'm going to do everything I can to try and help people so that they don't have to sit where I was sitting. And one thing I do need to mention is that the money that you have to raise for going for a transplant, we weren't told about the amount of money we needed to have until 26 days before we were required to have it. Nobody at Transplant had told us anything. Even though I'd been going through all the pre-testing for almost a year, we were told 26 days before my case was to be presented to the transplant team that I had to prove on December 13th that I had that money. We had 26 days. So the stress is crazy, but you got to do it if you want to live. And it's not right. It's adding so much stress to people when they're already at their maximum limit of stress, just trying to stay alive. But I'm happy that I'm here at the end of it, and I'm doing great. And I'm just going to continue to do everything I can to make changes so nobody has to sit in that position again.
Thank you, Christina. So I'm going to go into some recommendations because there is a way through this, and we're extremely excited about potential policy openings to address this kind of gap, I guess, for rural patients. The primary evidence from the study, as well as a really thorough review of interjurisdictional programs in Canada and internationally, kind of informed the recommendations. So I'm going to go through them at a high level right now, but I'm going to start with something that we're all really excited about, which was the context for this is a resolution that was passed at this year's UBCM convention, a Union of BC Municipalities in Vancouver, where delegates voted unanimously to advocate for funding for those who need to travel for access to healthcare. And I have to do a shout out to Paul Adams at the BC Rural Health Network, because the BC Rural Health Network really led the writing and passing of this resolution. This is where, though, the rubber hits the road in terms of actualizing the commitment contained in the UBCM resolution. So in a nutshell, we recommend the following. Overarchingly, we need patient housing, and we need a travel treatment fund for everybody that has to leave their rural community to come, by necessity, to come to a larger center, especially Vancouver and the Lower Mainland, to access healthcare. We need stable funding that's not isolated and kind of polarized by disease state. We need it easily accessible. And we need actual housing that's adjacent, hopefully adjacent to quaternary care hospital. So to actualize this, the comprehensive funding is needed for transportation, for temporary accommodation, for per diem to be covered for all patients that need even to go to a regional care center. And we've gotten uptake on this by the provincial government, and we're hoping we're going to be able to action this in the next couple of months. The provision of funding for out-of-pocket costs should be managed. We heard and we looked at other jurisdictions and found that established NGOs, for example, in Vancouver, like Hope Air, with an established track record and an existing infrastructure, is probably the most efficient way to go, but that's up to the people that provide the funding. We also asked that the City of Vancouver, supported by the Ministries of Health and Housing, recognize the potential for increased efficiencies by making available targeted, supported, subsidized patient accommodation as part of an integrated provincial strategy that addresses the needs of all patients, regardless of disease category, which we don't have right now. To do this, we need to accomplish this. We really need an interdisciplinary working group to develop housing options and the kind of requirements around how funding would be allocated. Because people are being called daily to come to Vancouver for organ transplants and other reasons, we need a critical response program. We can't wait for all of this to be sorted out. We need to bridge all of the funding that currently exists, and be able to add additional funding for relocation, for accommodation, for accommodation for a care provider, and all the things that we've talked about. We really heard from patients how difficult it is to navigate the system. There's an awful lot of medical appointments that need to happen specifically for organ transplant patients. And if you're going back and forth to your regional referral center, let alone Vancouver, on like a bi-weekly basis, that's really difficult for different appointments. If they can be organized through a system navigator, that would be wonderful. And of course, I would be remiss as a researcher not to emphasize the need for a quality improvement framework for any system funding that could come forward, to make sure with a particular attention that we're meeting patient costs, patient needs, as well as in a cost contained way. So ultimately, we need a provincial task force, supported by the Ministry of Health, to provide leadership in creating patient-centered solutions for rural patients who need to travel. Task force has to include representation from patients, communities, rural and urban healthcare providers, healthcare administrators, policymakers, nonprofits with a vested interest in this, like Hope Air, like Angel Air, Helicopters Without Borders, etc., decision makers and researchers. And, we need to have provincial leadership for global solutions. We need to bring together the interest groups and oversee the expedient implementation of a critical response program. So those are our findings and recommendations in a nutshell. I wanted to make sure I got through them in case there's any questions, because we covered a lot of ground here. So I'll just turn it over to Leslie, if you're facilitating, if there's any questions. Thank you.
I see one question in the chat around, has BC Housing been presented the information, and are they part of the discussion?
Yeah, so we're just doing this now. We had to, unfortunately, well, neither unfortunately or fortunately, we had to wait for the election to settle and the new government to be in place. And so now we're going full on. We're meeting regularly, and we're setting up meetings with BC Housing. You bet, that's a key player in this. And the City of Vancouver, who's got a vested interest in this as well. They've been very supportive. Councillor Pete Fry has been very supportive in this endeavor, and he championed the proposal at UBCM.
Awesome. Jason.
Yeah, thanks for that. It was a lot of emotion to hit us before 9 a.m. Christina, I'm going to be annoying and not ask a question initially and make a comment. I think, Christina, you've shown that all the hard data in the world can't convey what your story has, and really appreciate it. Just wanted to acknowledge your story and your vulnerability in sharing that story, because I don't know if I could have done it. So kudos to you. Really appreciate that.
If it makes change, I'm happy to do it.
Fantastic. Maybe I do have a quick question, Dr. Cornelsen. Forgive me if I missed this, but is there a baseline for those that are indeed falling through the cracks? As Christina mentioned anecdotally, that 4 acquaintances have passed away waiting. And I'm just wondering if we have any information on all of those that are sort of falling through the cracks, unfortunately.
Do you mean, do we have a consolidated understanding of how many people get off the list?
That's a better way to put it.
Yeah. We don't. We are anecdotally trying to gather that, and through reaching out and branching out into all parts of the transplant community, I was hearing anecdotal evidence that I was keeping track of, and I think Christina's, got it spot on. In the past couple of months, there's been 4 people, many more than that, who choose not to be on the list. And one of the reasons for choosing not to be on the list and not going into debt is a lot of people are concerned that they may impact what would be available or the financial recovery of their family if they were to pass after their transplant. So I've heard that from several people. But in terms of the numbers of that, no. I will say that there are system supports. If you make under $40,000 a year, correct me if I'm wrong, Christina, I think it's $40,000. You can apply for funding through the Ministry of Social Development and Poverty Reduction to have your costs covered. I heard from many people. Yeah, I heard from many people that the application process is quite entangled and difficult, and that it's frustrating for many people, which is why we're recommending an NGO outside of the ministries look after residual, funding that's needed in our recommendations. But Jason, that's a really good question. I think we do need to know. We also need to know, and what I would like to look at is the system costs for people who don't get their transplant, because if you don't get your transplant, you are going to be using hospital resources at an increased rate because you're going to become very ill. And I think we need to take that into consideration when we're deciding how to allocate money provincially.
Excellent, thanks. Mary, you had a question, kind of comment.
Sure. Thank you so much. And Christina, it's so good to see you doing well. Thank you for your story. So I was my brother's caregiver for his transplant, his lung transplant in the spring, summer of 2021. We came from Campbell River to Vancouver. He was receiving PWD before his transplant, during and before his transplant. So he was able to access Ministry of Social Development Poverty Reduction. It was a very seamless process. They were always able to accommodate the financial needs of his care and his accommodation and food and that kind of thing. So I just was commenting that perhaps just a research of what they're doing and how they do it. They have staff that are specifically required or tasked with those jobs. It did work really well. The rates were a little bit low. My costs were not covered, so any of my travel that wasn't with him was not covered, and all of the extra costs that I had for my time there was not covered, of course. But it did work for him. We were able to find an Airbnb. It was during COVID, so there was a bit more availability, etc. But just to say that I am so thankful for that possibility for him, because he was able to receive his transplant at that time. So thank you for all your work on this. It's a really important, as you say, for those of us living in rural communities, we travel many times for different kinds of medical care, and it is highly expensive. And so this is a great effort. Thank you.
Great. Thanks for that comment, Mary. And I do want to emphasize that there are agencies and there are funding pots for people. They're just a little bit, for some people, scattered. So, for example, we heard a lot from people who accessed Hope Air, who will get people down to Vancouver and provide limited accommodation, not for the duration post surgery, but will provide, accommodation around their diagnostics and stuff for a couple of days. So thanks for that, Mary. That's important to remember.
Do we have one final question for Jude and Christina?
There is one question in the Q&A box from Paul Adams, Leslie, just asking.
So
oh, was that already answered?
No, I don't think so. But Christina, he shared he knows your story well, but wondering if you could help share how many times you had to leave the community pre-op for testing and procedures.
Yeah, that's a scary number. I had to leave Princeton 53 times.
Wow.
Yeah. And some of the appointments were overnight, where you have to stay in Kelowna or in Vancouver or in Penticton, because you have to be within, the certain area of the hospital in case anything happens. Or they start a test on a Thursday, but they need you back there Friday morning. Well, I'm not going to drive home from Vancouver to go back there the next morning, and same with Kelowna. And it's just you have to take this on as a marathon, because that's what it is. But it's hard to run a marathon when you can't breathe, but you do it because you want to live. So you just put on your boots and away you go. But it's robbing Peter to pay Paul to save your life.
Oh. Thank you.
And just an add here is, once you have your transplant and you're doing great and you're back home, your medical appointments don't stop. Like, I had to go to Vancouver again last week, and I had to be there for 3 days, 2 nights. Well, I can't drive myself, so my husband had to take time off work. You've got a hotel for 2 nights, you've got food for 2 nights, you've got parking for 2 nights. It's constant for the rest of my life now, that those costs are going to keep being there, but at least I'm alive.
Thank you so much. Thank you, Christina. Thank you, Jude. That was an excellent presentation. And like Jason, just want to reiterate, Christina, thank you so much for sharing your story. It's hugely
For letting me.
impactful. And Jude and Christina can continue to answer questions, some of the questions that go into the Q&A box they have access to. So I think there's one or two more there that they can answer. But at this point, I'm going to hand over to Dr. Brenna Lynn. And
Good
she's going to kick off
morning.
our rapid fire. Brenna.
Great, thanks, Leslie. And what a great keynote. A great way to start the day. So insightful. Just wanted to introduce myself quickly. I'm Dr. Brenna Lynn. I'm the Associate Dean of CPD and very, very happy to facilitate and the beginning part of the rapid fire presentations for this morning. And I see our first two presenters here. And I want to acknowledge that today I'm working from home and I'm on the territory of the Squamish Nation in West Vancouver. And welcome everyone to reflect on their land acknowledgement as well. So our first presentation, this is a 10 and 5 format, around 10 minutes for presentation and then 5 or so for questions. And I wanted to introduce our first presenters, Dr. Neelam Dhaliwal and Janice Young, Dr. Janice Young from UBC. And today they're going to present their work with the title, Design and Implementation of a Regional Practicum Model in Pharmacy Education. So I'll hand over to you both. Thank you.
Wonderful. Thank you so much for having us both here today. And as Brianna has mentioned, Neelam and I are going to be presenting today on our work regarding implementing a regional practicum model in the UBC Entry to Practice PharmD program. So just to provide a little bit of context in our, next slide, please. In our Enter to Practice PharmD program, our students, our pharmacy students, need to complete about 42 weeks of experiential education over their 4-year program. And this is over 7 practicum courses that range from 2 to 8 weeks in length. And as a result, to ensure that they are able to work with a number of different patient populations in a variety of practice settings, they are completing these practicums in a variety of locations across the province of BC. Next slide, please. And so really our objective for this work was to develop, implement, and evaluate a regional practicum model. And this is where students would complete a series of their practicum courses within a dedicated rural, remote, or regional practice area. And the intention is really to help students establish themselves within these communities over a longer period of time. So the Regional Practicum Model, or RPM, does not seek to change program requirements or course expectations, but we have a few goals that we're hoping it will achieve. Next slide, please. And so the working hypothesis is by having students complete a series of their practicum courses within a dedicated geographical region versus relocating to a number of different areas each time they are in a new practicum course, this will hopefully ease student transition and relocation. It'll help provide some unique practice experiences and patient care experiences for our students. We also want to create some space for students to develop deeper connections to underserved communities in BC, and as well increase student interest in the practice needs and potential career networking opportunities within these regions upon graduation. And all in all is to really help support the healthcare needs of populations in the underserved areas and remote communities within BC. Next slide, please. And so our research questions surrounding this work is, how does the implementation of a regional practicum model contribute to pharmacy student experiential learning in the UBC E2P PharmD program? So specifically, what are the impacts, what are the benefits, and what are the limitations? So I'm now going to turn over to Neelam to carry on and tell you a little bit more about the model itself.
Janice, and thanks everyone for joining today. Really interesting topics that are being covered, and really appreciate the key presentation as well. For my component of the presentation, Janice and I just want to sort of the steps that have been taken to date. As we mentioned, this is really a thing that sits within our program at UBC, but our students are connecting with communities across the province as early as year 1, and then for most of actually year 4, where a lot of the learning takes place. So within the regional practicum model kind of project plan, these are the steps that we've undertaken to date, and we're happy to share, and I'll share a little bit more in detail, but we've really launched our pilot past summer. So we actually have students participating in communities across BC within the regional practicum model at this time. And really, I think when folks are maybe listening to how we're describing the model, it is really inspired by and kind of leveraged from the information and evidence around sort of the integrated clerk model that we have with our medical program within BC, and similar types of models where there's a longitudinal approach to experiential learning and health education. So some of the key things that I'll highlight within each of these steps that we've undertaken are just that when we first started this, we were surprised to see that there really wasn't a similar model within pharmacy education. And so it was kind of a bit of an aha, like, oh, why haven't we really gotten there yet when our students are really a lot of time across the province? And in BC, sort of, uniquely positioned in that we have, a core educational center within the Lower Mainland, but then we also have these opportunities within our partner health professions education programs across the province as well. Our students were really keen actually for this idea, and so that was one aspect that was important for us. Janice and I had worked in rural, but we really wanted to ensure that this with some of the desires that our student body had as well. And so many were interested in participating, and I think because it allowed them to sort of conclude their formal education at UBC in Vancouver in their year 3, and then kind of journey back to their communities or in communities where they see themselves working for their 4th year. But I'll share a little bit more detail about the model in a moment here. With the support of actually the Rural Coordination Center, we were able to host also symposia for our practice educator partners or pharmacists that lived and worked in some of the communities where we were hoping to host our pilot years for the regional practicum model. So that was important, again, to kind of get that perspective from those stakeholders that this idea resonated, that it would be meaningful for them as individuals that would be supervising and supporting student learning, and that they found it of value to their community as well. And so there's some high-level points from those steps shared there on the slide, but I'll move to share a little bit about the model itself. So as Janice mentioned, we have experiential learning throughout our program from years 1 through 4. The RPM, however, centers on the latter year. Between year 3 and year 4, our students actually embark on 32 weeks of rotations. So usually starting from all the way through to April of the following year. And so that's where we centered the regional practicum model with sort of our advanced learners and within this kind of longitudinal stretch of experiential. You can see in the top box in blue there, our pilot year, we had 7 students. So those students are on rotation now in kind of their continuum of experiential weeks. And then we've actually gone through the opt-in process for our students for the upcoming summers, starting from May 2025. And so we were able to have 10 students in to participate for the upcoming year. So one of the biggest questions from our students was like, what's the region? Where can I go? What's the definition? And so we were able to leverage some of the work within our office just around how we had defined regions for our practicum process in the past. And so we didn't sort of look at how to define rural or remote. And I'm sure, as you're looking at the tiles across the screen here, some of those are definitely not rural and remote keys or towns. But we wanted to have the ability be to still host the core rotations that our students require. And one of them is an inpatient centered rotation. And so we had to kind of bridge our requirements within our program with our desire for students to engage with communities across the province. And so you can see the region definitions are expanded a little bit using our placement processes. But for example, within Kelowna, that would include communities like Winfield or Lake Country as well. Penticton included a few other areas within that region, and so on across the board. The blue tiles are the regions that we introduced for our pilot last year. And this year, able to add Prince George and Victoria due to the ability from our practice educators and pharmacists in those areas to their interest in supporting student practicum placements in those regions. So I'll just briefly touch on the evaluation plan as well. So as Janice mentioned, we kind of entered this pilot with the desire to just explore and understand what this looks like for our program within BC, and also understand sort of the impacts both for student learning with our practice educators or supervisors, from the pharmacists that are supervising our learners, and then also within the community context as well. You know, was there a change in the way that students were able to support the health and well-being of populations and communities across BC. We're also looking at sort of the benefits across the board and then the limitations and challenges. And some of that already kind of came up in our first pilot in that we had to really share more information and really get students interested in this model and idea. And given that it's an opt-in process, we are really happy that we were able to meet our goal of you know, that initial cohort being able to participate in the model. We do have a pre and post evaluation approach or design. So we've had some opportunities to understand why students wanted to participate in the model, what they were hoping to gain from that experience. And then we'll be looking again once they've completed their rotations in April at sort of how the experience went and what it looked like for them.
It was the lady, the person talking.
Sorry, someone's come off mute. Sorry, someone's come off mute.
No problem. I'll just maybe continue on. I'm on my last slide, and I think I'm at time as well. So just wanted to conclude with some acknowledgements. Both for Janice and I, we really acknowledged.
So they're trying to create a provincial patient network.
Maybe we can just ask people to mute.
For medical care outside of them.
I think somebody's on a phone call and probably doesn't realize that they're off of mute.
Okay.
Okay.
No problem. I'll maybe just take a look at, oh, there we go. So I think it's quiet there, but we really just wanted to also acknowledge all of the partners, the students, the resources that have facilitated this process and allowed us to explore this model with our students and within this educational context, but really with the desire to impact, you know, care and patient experience across the province. So I'll leave that slide up for a moment, but I'm happy to take any questions. Janice and I are happy to take any questions.
Great, thanks, Neelam. Thanks, Janice. That was great. I'm sure there'll be lots of questions here, and really interested in some of your thoughts on the findings in the next stages. Any questions? Don't be shy. Raise hand. Drop in the chat. Whatever you would like. Maybe I'll just get us warmed up here a little bit. I love the idea of the symposium, and I'm wondering if topics of the faculty development pieces of being, I guess, preceptors or hosting learners in the community over the practicum, if that came up. And then my second question is, was there team-based care opportunities for the pharmacists, or were they more assigned to direct kind of pharmacy care?
Really great questions. Neelam, I'll let you perhaps answer the first one. Just about preceptor training or practice training.
Yes, absolutely. Absolutely. So thanks for that question. That's actually my other hat, is I support practice educator development within our program as well. And so, yes, it certainly came up that, though we're not changing the course expectations or requirements within the curricular pieces within the model, preceptors really wanted to kind of understand how best to engage with students in this more longitudinal approach. And so we've worked on a little bit, just kind of having a more loose orientation for those folks that are involved in the RPM. Within the current cycle, all of the preceptors were actually, or most of them were actually experienced preceptors. So they had already undertaken student learning in the past, and the kind of course pieces remained the same. So we're hoping to explore what that looks like moving forward as we onboard new sites or have new experiences within the regions for students. But definitely is front of mind for me, since it's part of my portfolio for sure. And then Janice, did you want to chime in on the team-based care component?
Yeah, and so again, like, we absolutely encourage the team-based care and working with other health professionals, and this is part of sort of our curricula course requirements as students are participating in practicum. And so again, not specific, just only using sites such as that, but absolutely looking for those opportunities for our students to work with other health professionals as they're on practicum.
Great, thank you. Well, lovely talk. We're going to move on in the interest of time to our next presenter, Dr. Mike Figurski. Hopefully I'm saying that properly, from the Stonebridge Clinic in Big White at UBCO. And Dr. Figurski is going to present on integration of a local LLM for transcription. So over to you.
Hello, everybody. My name is Mike Figurski. I guess I should introduce ourselves first. This is Sarah. She helped me on the project along with several other students. Through funding, I suggest all researchers look at NSERC and other opportunities to get at least 50 to 70% funding of graduate students into this project. I've never had a request denied, and I've made over 30 of them. So whatever you're interested in, I think there's money and highly qualified, motivated student to help you. All right, let's go to the presentation. So, sounds like someone's talking in the background.
I'm just saying.
Yeah, maybe we can just ask everybody to mute their line. I think it's still the same. I think it's still coming from the same person. Tracy, any suggestions here?
The only lines showing unmuted are actually the presenters, so I'm not quite sure. So please, everyone remove your line.
I think maybe there is one that I'm seeing that's not muted.
No, it doesn't. If you're not ready.
Okay. Would you like to send it to me in the chat, Brenna? And I can.
Sure.
Thank you.
All right, I'll talk over them. My interest in this was there's a real movement towards scribes and automated interpretations and note production from big players like OpenAI. And surprisingly to me, physicians and health organizations are clamoring to export their audio in return for payload of a clinical note, which, aside from the obvious data sharing, personal health information concerns of having your information out there, no matter what you hear, no matter what anyone says, certainly on an aggregate level, anything we say and is transmitted to transcription services becomes part of their later model. And I think it's a real, outside of the inefficiencies of doing this as a third-party service, there is a real question of, has a patient signed up for this? So what we wanted to do was to use a local language model, which is open source and free to everybody. It was released by OpenAI a few years ago as a proof of concept. And we've incorporated it on a high-end GPU computer in the back of the office here, so we can do our own transcriptions. Basically, I'll dictate a note that's transcribed live into the patient's chart in the EMR. Simultaneously, an audio file is transmitted over the internet back to this same office, where it's transcribed and sent back to the EMR and automatically integrated into the patient note. We had several people participating on the project. Most of them funded students, a couple of them full-time, full-stack developers. We've got one who's since returned back to India, Sam, and Sarah, who's been working here in the office, along with a few graduate students from Simon Fraser who worked on the model over a 4-month internship in the summer. All the information in this is free through the GitHub repository, which will be shown at the end of the lecture. So Whisper is a language model, is basically predictive word anticipation based on previous context. So every word is based on the previous word, is based on the previous word, largely in blocks of context, 8 to 15 words, where they'll determine what the likely next word is. And this is done in blocks in packets, really. So the objective of this exercise was to have better accuracy in transcription, to involve the patient directly in creation of the note by letting them observe you, see it being transcribed on the screen, and then they receive a summarized, corrected document of the visit. And we wanted to do it locally. What we found was, compared to 3 years ago, we were using, operating system transcription services like iOS or Google Speech to transcribe directly into the patient record, and then we'd go back and correct it because there was a lot of errors. But it got remarkably better over the last 2 years, just in the operating system itself, without any machine learning or local language interpretation. Still, there was a lot of errors. Maybe in a minute of context, even with trying to enunciate properly, you might have 10 or 15 errors, half of them being grammatical or punctuation, the other half being substantive words or errors. And what we found, that using this model, which was trained on about 1 million hours of actual transcribed dictation, that's where a human goes in and makes the correction. That's a lot more valuable to the language model than when the machine corrects itself and submits that. And there was about 4 times as much of that type of parameters in the model as there was the directly transcribed and corrected by human. So ChatGPT has maybe 100, takes 100 gigabytes of GPU RAM. A typical gaming computer might have 6 or 8 gigabytes of GPU RAM. So you would be very expensive, probably $100,000 to set up a local transcription model using the equivalent of ChatGPT, which can be done. It's still open source, and you can implement it on your own, a version of it anyway, on your own systems and use it for transcription. But what we could accommodate was a 10 billion parameter model called Whisper, which is released under open source. It's Apache 2, which means that you can use it for anything. You can charge for it. You just have to release the code to people, and you have to attribute where you got the code from in the first place. It takes about 5 seconds to transcribe the audio file, which is an MP3 file, to the computer in the back, for it to do the transcription and send the text file back to the EMR. We were able to create automated integration, so it's seamless within the EMR. You just go to the place where you dictate the note, and it produces the text that is returned. The benefits were better accuracy. The information never leaves the office. It's encrypted, hard-coded here, and not used for anything else. It's already part of the existing workflow, so there's no additional steps, and it's free. And probably the biggest benefit for me was that doing it in front of the patient, people remember, you know, half of what they read and most of what they see. But if they hear it, see it, participate in it, see the live transcription, it's an experience that they're much more engaged with and likely to remember. So here's a typical example of native transcription using, I think this was done using Google speech to text on an iPhone or on a Google Android phone. And here's the corrections, the changes that the model made. It's assuming that the green sections are correct, and in fact, they overwhelmingly are. Here's some statistics on the amount of errors that were made. The most important part on this scale, if you look at the second and third, or the third and the fourth columns, you'll see the errors between Google transcription and Whisper, which is quite substantial. Here's the actual box itself, sitting in the back with a 12 gigabyte GPU. That's a video card that does most of the heavy lifting in transcription. You don't need a powerful computer. You don't need a lot of RAM processing. A standard desktop in today's model would be enough, but you do need a really good video card, which might set you back $1,500. I'd like to mention briefly the funding opportunities for this. There's something called the Canadian Digital Adoption Plan, which is funding from the government to allow businesses to integrate a digital strategy into their marketing plan. It pays 90% of a consultant's fee, up to $15,000, to come in and give you advice on how you can implement such a plan. We found an expert here in Kelowna. He came and worked with our team once a week for about 12 weeks and helped us put us on the right path. They're the students and myself who worked on the plan. MyTax is an ongoing project that is for any kind of research. It's put on by the NSERC, National Scientific and Engineering Research Council of Canada, that will pay 50 to 70% of students that you bring on for typically 4-month terms. These are postgrad students, so they've already got an undergraduate degree. And the advantage of the MyTax program is you can have international students with their expertise. And the ongoing undergrad program is called the Student Work Placement Program. It's a rolling intake, and they go by terms. Yesterday, they opened up the winter term, and basically what they'll offer you is in your area, whatever the minimum wage is, they'll pay half for any student, for, in my experience, pretty much any project if you apply early on. They'll pay 70% if they're visible minorities, if they're first-year students, or if they're refugees, or they have some disability. And finally, here's the resources. All the resources mentioned and the code mentioned on this talk are available at visacan.com/whisper. And there's our contact. If anyone has any questions, feel free to reach out.
Great. So I see we have some questions. First from Catherine Bell. Catherine Bell says, I'm a new faculty at UBC. Can you tell me more about how it works to recruit a student, resident to work on your project?
Sure, there's a couple of funding sources, but most of the providers, the government comes out with big lumps of money and they call it different things depending on who's in power, but it's pretty much the same program that's run by third-party organizations who supply the funding, get the paperwork, and then reimburse the researcher. If you're looking for undergrad students, which is there's less of a payout for that, because frankly, unless you find someone with a vested interest or clinical or some sort of experience, they're like first or second year medical students. You'll spend as much time teaching them as they will helping you. The program I'd recommend for most research would be the MyTax NSERC program, which pays about half of an intern's salary. Typically, you'll put in about $6,000 or $8,000, and the government will put in the same to cover a 4-month dedicated intern at a post-secondary education and post-secondary institution in BC. The best way to do this is through the faculty themselves. Figure out what kind of student you want, and then approach the counselors in that department and ask them if they have any students in mind. And then you go on to whoever the provider is. There's Magnet, there's ICTC, other for-profit information companies who will help you set up this internship and apply. You apply through their portal and website. It only takes maybe 6 or 8 hours of actual paperwork to fund a position, start to finish.
Yeah, great practical resources, and an amazingly timely topic as everybody's kind of grappling with the use of AI and these type of products for practice efficiency. So thank you. There is another question in the chat. Maybe you could answer that through responding by text, so everybody can see. And I want to thank you. We're going to move on to our third presentation. And I see presenters. We have Dr. Melba D'Souza and Michelle Smith from TRU, and they're going to present on co-creating community engagement forums for sustaining partnerships and networks through knowledge translation World Cafe Summit. So I'll hand over to the next presenters. Thank you.
Hello, good morning, Dr. Brenna Lynn. Thank you so much. I'm just curious if you can hear us and also see the slides.
Yes, everything is good from my end.
Okay, thank you. So the topic that we are talking today is about the community engagement for sustaining partnerships and networks, a knowledge translation that we worked with our partners. I like to acknowledge Thompson River University campus on the traditional lands of the Tecumseh Secwépemc and the Texic within Secwépemc Ulu, the traditional unceded territory of the Secwépemc. My name's Melba D'Souza. I am a professor at the School of Nursing Population Health, Thompson River University, and my program of research includes psychosocial oncology, rural health, immigrant health, mixed methods, and health policy. And I have my partner with me today, Michelle Smith.
Hello, I'm Michelle Smith, the Learning Health Lead for Interior Health Region, and I'm based in Sioux Nation, and I cover the Interior Health Region for the 7 Nations. I'm happy to be here today. Thank you.
And we have another student who's not able to make it today from the UBC, Ashwin Nairi, who has been part of the Population Health Aging Rural Research Center at the School of Nursing and has worked with us on this research project.
And today we'd like to talk today about, so our objectives for this program is to co-create a community engagement knowledge translation and engage in critical, reflective, and facilitated dialogues to enhance health promoting behaviors for cancer prevention and screening practices with a focus on post-cancer treatment. So what do we do? We will be reviewing, sorry, skipping to the next, thank you, Melba. It's okay, I was like tongue twisting myself anyways. So we review recommendations, strategies on reducing barriers and improving facilitators. Thank you. So we're based in implementation science, and this is our theoretical framework we developed. We placed it in the daffodil. It's very cancers. Everyone I think recognizes daffodils as part of the cancer promoting. And the STEM is growth and development based in history of daffodils and cancer care. And on each of the leaves, you can see there are different groups that are involved as, for example, support care services, social support networks, person-centered care, team-based approaches, transcultural mapping of lived experience, and community partnerships, population, social, cultural health. And our leaves also, as a group of that entirely, is our healthcare practitioners or community service providers, advisors, people with lived experience, caregivers. So it's kind of a full scope of, we bring a lot of different people in. Next slide. Our goals for our research is to facilitate cancer care research-driven discussions and dialogue about practice issues and efforts to share innovations. And our focus is knowledge translation, decrease awareness of the improving psychosocial oncology, and access and use of resources to community and creative networks. And I think it's amazing what we found through the process and engaging with the larger community and everyone. We'll share more. Thank you. So our methodology included community advisory boards. We identified shared goals, priorities, responsibilities. You can see we have a full list here. We are embedded in community participatory action research. We have 53 members across British Columbia participating in knowledge translation. We just did in February a World Cafe, including discussions and facilitation, and are all based in thematic analysis. So on February 2024, we had an All Translation Summit. We had presentations from international speakers from Thompson Rivers, UBC, UVic, students and faculty members, as well as people with lived experience, caregivers, and community-based organizations that support the project. Or sorry, the wider summit. Thank you. And we basically did this in a theme-based approach. It was led by one of our patient advocates, Colleen Farron. And across many themes, one of the most largest one we had was voice being heard. Thank you.
Some of the results that came out from this knowledge translation in action, one of the goals was how can healthcare practitioners facilitate open and effective communication between patients living with cancer to ensure complete understanding of their cancer, illness, and treatment plan. One of the main themes that came up from the dialogues were enhancing communication and the clarity of communication in cancer care when we interact with patients, the caregivers, and the care partners, and use of and the role of technology for accessibility with clients in rural and remote communities. The second goal was on what ways can patients, caregivers, and healthcare practitioners collaboratively address psychosocial challenges that are associated with cancer treatment and post-treatment. One of the main themes that came up was navigating psychosocial maze in the whole cancer journey and recovery for the patient living with cancer, and this focused on multifaceted psychosocial hurdles, distress that the person who is affected with cancer is. And the most principal question is, what do I need to thrive to get across my cancer journey? The third aspect was, what are the innovative strategies that healthcare practitioners can employ to empower the patients and caregivers to actively participate in the decision-making process related to cancer treatment and its post-treatment. One of the main themes that came up was cultivating patient autonomy in cancer care, and the discussions revolved around empowering patients in the decision-making process with a good grounded knowledge, information, and the process of cancer care. The other aspect was, how can healthcare organizations create a supportive environment that encourages ongoing communication between the patient affected with cancer, their caregiver, and the healthcare partner or the practitioner. And the main theme that came up was how to foster a collaborative ecosystem for the person involved with cancer or affected and the cancer supportive care. And these discussions involved streamlining and integrating the coordinated services of cancer care and dismantling the systemic silos and enhancing communication between the person living with cancer and their practitioners and family. The last goal was how the evolving information through communication technology and how can digital tools be used to foster continuous communication and collaboration among the patients. And the main aspect that came out from the group discussions was integrating couple of digital tools for providing holistic cancer care, and this focused on improving continuity of care, the coordination of cancer care in rural and remote areas of British Columbia. The other question was on what are the innovative strategies and ways to ensure collaborative cancer care supportive services across the different ages, the genders, culture, socioeconomic and rural communities of people living with cancer in BC. And the main emphasis was on using an integrative community oncology network support for comprehensive cancer care. And these discussions focused on getting across equity, EDI, demographics, and geographic locations in rural and remote areas of BC. The discussions and the conclusions came up to 5 main areas. One was education and training for primary care providers. Second was integrating patient care outcomes in their electronic health records. Third, increasing community awareness, community education and navigation programs in rural and community areas, increasing the services of mobile screening units. And fifth was using very specific cultural tailored education campaigns in rural and remote communities. The main evidence that came out from this knowledge translation action was identifying specific social determinants of health and barriers in the care in cancer. Second was identifying specific policy advocacy for people working with the community in this rural and remote areas. Third was developing networks and cancer care specific models in rural and community areas of British Columbia. And the fourth was increasing community engagement in rural and community remote areas. The implications for practice were increasing community and physician relationships, developing culturally competent training in undergraduate and graduate healthcare programs in BC, providing and emphasizing on culturally tailored policies, and increasing family and spiritual support in the cancer care journey.
So from our work in this summit moving forward, we have our next steps. So developing integrated community oncology networks, community engagement forums, and person-centered navigation and education. And you can see on the tree, we developed that was at the summit as well. And everyone kind of put their place where they were. And you can see, I don't know how well you can see it in the screen, but patient, caregiver partners, family, community, service providers. So that was a very visual way to represent the collaborative partnership. We like to acknowledge our partnership and collaboration with, I won't list them all, but there's a number of them there. And we like special acknowledgement to our patient advocates, Colleen Foran and Anne McCarthy. I mean, Melba's been doing an amazing group with developing such a community of partnership. And on the right, you can see what kind of the themes that came out of the summit: community experience, intersectionality, equity, survivorship, and all based in the framework of the Daffodil. We have references. We can, if you request them, we can send them to you. There is a click link there, but I think next slide, if you'd like to connect with us. Our amazing Dr. Melba, founding sources. Myself or Ashwin, and then our funding sources and our partnerships, or sorry, acknowledge our partners.
Thank you, Michelle. Wonderful presentation.
Thank you.
Great,
Good job,
great,
Melba.
interesting topic and well presented and such impactful, important work. So thank you for sharing. We have a time for maybe a question or two, and opening it up if people want to ask. Feel free to put something in the chat. Maybe I can get us moving here a little bit and start it off. Was just mentioning the collaboration with the Cancer Agency, and I'm wondering if there's any of the findings that they're going to take forward for action, and what would be your top recommendation to a policy, or in this case, BC Cancer Agency?
Yes, one of the top one was increasing cancer navigators and also cancer education in the rural and remote communities where a person is affected before screening, and helping and supporting them through the necessary education they have. So that is one of the top one. And the second was working with developing integrated community oncology networks, further strengthening that in rural and remote communities of British Columbia, especially where we live in Kamloops and its surrounding 10 rural regions, Revelstoke and Williams Lake across that. These are the two top main recommendations that we are working on and helping and growing with them. So we are developing an intervention with BC Cancer. We put in an ethics application for through the Breast Cancer Society of Canada and BC Cancer and Interior Health. That's on developing an intervention for cancer navigation, having professionals as navigator roles and peer support groups for people affected with cancer, especially with breast cancer.
Thank you. I think we're going to move on to the next one, and I'm wondering if you or Michelle Melba could answer the question in the chat for me. I'm wondering if there was any finding that was really surprising to either one of you or to the study investigators. I'd love to hear your response to that. Maybe you could add a couple of words to the chat. But thank you. This is a great presentation. I really appreciate you sharing. We're going to move on to our next talk from Nicole Hallbauer and Michelle Roberge, and they are going to present on their HEAL project, Hearts-Based Education and Anti-Colonial Learning. So I'll hand over to the next presenters.
Good morning, everyone, and welcome to our presentation. We're so grateful to be here to talk about our wonderful website.
I've lost Zoom. Just a minute.
Okay, I'll just introduce myself. Amasa Echstam Hana Achtawayu, Kitsum Kalem, Diwal Watku, Ganhara Dipteku. Hello, everyone. My name is Nicole Hallbauer. My Tsimshian name is Achstam Hana'ach, which means victorious woman. I am from the Kitsum Kalem Ganhara Raven clan from the House of Gom. And I am coming to you from my own traditional unceded territory on the banks of the Skeena River. And my co-presenter, that's the last page, is Michelle Roberge.
Hi, everyone. You can see the slideshow now?
Yes.
Yes, okay, good. Hi, my name is Michelle Roberge. I am zooming in from the traditional unceded territory of the Sycus First Nation here in the center of the province, colonially known as Vanderhoof. I am part of this project with the Health Arts Research Center as the digital archivist. So I built the website essentially. So next. It's a little bit delayed. There we go. We also have an amazing team that put this together. Just wanted to acknowledge on the far left there is Lisa Monroe. She provided incredible administrative support. Our fearless leader in the middle there is Dr. Sarah DeLay from the Health Arts Research Center. And then in the gray sweater is Lisa Striegler, who is another research manager. And so, yeah, and then Nicole and I there. And this is when we presented at the launch of this website.
Thanks, Michelle. So we came onto this project and there was this huge goal to transform the hearts and minds of health providers, learners, educators, and administrators. The thing for me was that it used arts-based learning, which I had not done before. I am strictly a spreadsheet person prior to this project. And I thought, well, spreadsheets are necessary everywhere. Throughout this whole journey, I've discovered a very artistic side. And I hope that as we go through this, you'll start to see where this can fit into your life as well. So what HEAL stands for is Hearts-Based Education and Anti-Colonial Learning. And it's not just about Indigenous health or anti-Indigenous racism. Many times people, when they see us presenting, that's where they think we're going. It's really anti-colonial, so it's a real stretch. Maybe next slide. Michelle, it's a real stretch of your brain. And I have found that in 30 years of cultural competency and cultural safety, that all of that is about what other people can give you. What we've created here is a body of work, a body of curriculum that really focuses on what's inside of you, what your biases are, what biases you bring to your space, what biases you bring to your interactions with others. We know that our biases, especially in healthcare, and throughout the healthcare system, there's a lot of issues that need to be addressed and that create health disparities. We really wanted to address what those health disparities are. I have a lot of stories I tell here because as a Tsimshian woman, my family is filled with generations of harm that was done due to bias. And I think for this presentation, I'm just going to say my mother experienced racism in healthcare up until her passing from breast cancer at 42. My sister experienced racism until her death at the age of 42. Both things, had there been more of an anti-colonial approach and an acceptance of who we are as people, may have prolonged their lives a bit. My daughter, who is 27, she has a piece on this website where she talks about what it's like to go into a marriage with me, her mom, a Tsimshian woman, or her father, who is not Tsimshian, who is very clearly white, and the difference in the treatment that she experiences between the two of us and why she chooses to go with her father. So what's really valuable to me is that this website addresses your internal bias. It says, hey, maybe let's take a look here, and let's take a look at how that impacts the care that you're providing. And here's different ways that we can think about it. And instead of just taking the extraction of what colonial Canadian history has taught us. So next slide, Michelle. Oh, so why did we use art? Oh, well, we have this construct, this colonial construct in our mind that to be a rational person, often associated with masculine and scientific and valid, you need to really disengage your emotion heart center, or what is often framed as the feminine side. We use art to bring you in balance as a whole person. When you're in balance as a whole person, then you have a greater opportunity to help others, because it returns that empathetic heart of yours into the work that you're doing. So every piece of curriculum on this website is rooted in art. You will create everything. When we talk about art, we don't just mean poetry and painting. We mean cooking. We mean, there's a cooking show with 3 generations of Filipina women. There are horse equine body language curriculum. There's painting and poetry. One of the most profound pieces of this work is by Dr. Shannon Webb Campbell, where one of her poems just broke my whole soul wide open when I read it. And it was, I'm a translation of a translation. And I just felt that so profoundly from her poetry, that it was so inspiring. And I just feel like every piece of curriculum is put on here from people with lived experience in our culture, in our society, in our healthcare system. And it's so diverse. All of the art is diverse, and it really moves your heart. And that's really what we're trying to do. Next slide.
All right. So that was the why. Nicole is the why of this project, and I'm the how. And so what did we do to get to the idea, to the website? So this is Dr. Lisa Boivin, an amazing, talented artist. And she created this logo that's in the middle of the page here. And that formed the basis of moving forward in an anti-colonial way. And you can see the importance of those 3 images within this logo. And so that was, you know, the non-hierarchical relationship and the communication and the kindness and the love. That's what sort of we always kept with us as we move forward, and creating a website that in itself also should reflect a sort of an anti-colonial approach. So here are 2 graphics, and so I'm going to try to speak to both of them. So how we went about this is Nicole met with 30 or so artists and creators and people with lived experience, like she said, and academics. And each of those individuals or groups of people created something, and it was based on their own experiences. And so we took those curriculum that they created, and we needed to present them in a website that's free and easily accessible. And so how we organized them was not, we thought, okay, this isn't a curriculum that you start here at A and go to B and go to C and go to D, and then you do the final exam and you're done. It's not what this is. This is a personal journey to address our own biases. So we organized the curriculum by their biases that they address, and a lot of them address multiple biases. And so this basket that you see, this is actually Nicole's unfinished basket that she made and photographed in her front yard and now is living on this website forever. And the intersectionality of the biases and how they interact and how individuals interact is represented within this basket. The weaving, the overlapping, and how it's unfinished also represents that this work is never done, and we're always working to be better and to continue forward. So we have these 25 to 30 curriculum that these individuals and groups have made, and we've organized them by the biases that they address. So in the left image here, I've taken for the biases out: sexism, ageism, ableism, and racism. And then below that, there are these three curriculum that I pulled out, all address overlapping those. So graphic medicine addresses ableism and racism. Chronic pain addresses sexism, ableism, and racism. And so as you move through the website, you click on a bias, and that will give you all the projects, all the curriculum that address that bias. And then you click into that, and that's where you get to the lessons. And some of them are extensive. There are multiple lessons, could take weeks to complete, full syllabuses. We have to a children's storybook that you on your own, or as say a lunch and learn with your colleagues, can read, go through the questions, do the self-reflection, do the art activity if there's one, and sort of complete it neatly. So that's how this is organized. So it's really a personal journey. There's also a journey with your colleagues, and it's for providers, administrators, educators, and all of this. If you are an educator, we hope that a lot of this can get incorporated into the work you do. So I think I've covered all of these 2 slides.
Yeah, so, and we're coming up on time.
Yeah, we're coming up.
Carry on.
So this is the landing page of the website. There is, we're not going to watch it, but there's a animation, a 3-minute animated video that we encourage you all to just watch. It just explains further before you dive into the curriculum, which we know you'll all participate in. This is an example. I don't know if we have time to go through it, but
no, I just this is one of the examples from one of the members of the HARC team, soon to be Dr. Vanessa Mitchell, and she has used a really traditional Syilx way to tell the stories and why stories are important, and so that's really valuable. And so you can see that she has 4 videos here, and that is there's so much we could say, but 10 minutes. This website is amazing, and the key here is that it's open source, it's accessible, it's free, and I tell everybody I meet about this. It isn't just for healthcare providers. This is for educators in schools, elementary, college, university, high school. There's something on here for everybody because it's about internal work. Here is some feedback. Here is some feedback that we've received on the website. And then I guess we'll just go on. These are our funders. Thank you. We live in a capitalistic construct, so we always need somebody to give us money. And here's the website. Please go check it out. We love feedback, and that would be fantastic to hear from people. So I'm hoping we have time for a few questions.
I do see, are you presenting this work in a larger format elsewhere? Would love to know more. We had a big national launch on August 16th, this past summer. but we're continually promoting it. And so email us. I actually don't have our emails here, but message us or chat or whatever it is in here. We can share more, answer questions, but we really encourage you just to go to the website and have a look and watch that animation too. And our contact is on the website.
Amazing. Yeah, this is great. And so it's such a great resource. I'm sure you're going to have people contacting you, and for sure, I'm going to look at the website myself as well.
Excellent.
I love the testimonials too of how they're using this with students. So
yeah. And that was the
amazing.
initial goal. So
Yeah.
So that's great.
Great. Well, I'll introduce our next presenter, Allison James from the Rural Coordination Center of BC. And Allison is here to share work on type 2 diabetes remissions in rural communities and application of community engagement. Welcome, Allison. Over to you.
Thank you very much, Brenna, and good morning, everybody. I'm delighted to be here. I hope you can all see my screen. I'm calling in today from my home, and I'm located on the beautiful, beautiful traditional and unceded lands of the Comox First Nation on Vancouver Island. And this picture here is looking out over Goose Spit, which is an area that many people recreate on, and it's been an area where traditionally it's been used for fishing and gathering. I just want to make note of these stairs up here, and this project has been a one-year project that we've been embarking on, and it just finished last week. So this is really a work in progress and more of a quality improvement project than a research project, but worthwhile to share some of our learnings from the community engagement piece of it. Like Brenna said, this is a type 2 diabetes remission in rural communities and application of community engagement, and this involved a large number of people. I'm just the person here today presenting on behalf of our team, which is listed below. In terms of an introduction, the impact of type 2 diabetes across Canada and across the world is enormous, and it's growing. The toll of type 2 diabetes is even higher in rural, remote, and Indigenous communities. And type 2 diabetes has generally been a story where it's progressive, it's chronic, and the story of hope has not always been embedded in this disease. In the last 10 years, there's a growing body of evidence that's showing that remission or reversal of type 2 diabetes is possible using food-based approaches, meaning that many people can come off of their medications that they are on or reduce the medications that they're using. Remission rates of up to 50 to 77% have been reported using food-based interventions. This new diabetes remission paradigm is really an emerging area, and it's not widely incorporated into current medical practices and diabetes supports and services. So this is why we were interested in doing this. It is captured in Diabetes Canada clinical practice guidelines as one of the areas, and it's been a fairly new area. Our objective was to successfully engage 2 rural communities and nearby First Nations, Port Alberni and Tumbler Ridge, to mobilize the evidence of type 2 diabetes remission and to develop a community-driven plan for providing culturally safe, patient-centered supports and services emphasizing food-based intervention. And the 2 communities were Port Alberni, which is about a community of about 30,000 people. It serves as kind of a regional hub of the area in the middle of Vancouver Island. And then Tumbler Ridge is located up in the north of our province and is a population of about 3,000. Is mainly a resource-based town with now growing ecotourism as well. So what we did was we partnered with 3 provincial level organizations, the Rural Coordination Center of BC, the Institute for Personalized Therapeutic Nutrition, and the Institute for Health System Transformation and Sustainability. Those logos are on the bottom there. And we applied to Healthcare Excellence Canada for some funding to do this community engagement project. We engaged with 2 physicians working in 2 rural communities. And what we did was we created a community partnership table using what's called the Partnership Pentagram Plus model. And they were supported by a community engagement coordinator. In terms of this goes off the script of being research, and this was largely a project evaluation where we used core team reflective practices to generate our lessons learned from our community partnership tables, the communities, and the project team. So in terms of the community engagement model, we utilized a model called the Partnership Pentagram Plus, where we developed a community partnership table in each community with 6 different types of partners: providers, community members, policymakers, health administrators, academia, and linked sectors. And linked sectors are things like businesses and not-for-profits who inform the type 2 diabetes remission work. This approach really recognizes that we need a diverse group of people and partners to solve any kind of problem, like trying to address type 2 diabetes in a rural community. Examples include the pharmacists, local physicians, dietitians, educators, health diabetes educators, health authority members, community members, local food organizations, and local businesses and industries. The community meetings were facilitated using an appreciative inquiry approach, which focuses on identifying and building upon the strengths, successes, and positive experiences rather than the weaknesses and the problems. This takes participants through a journey of discovering, dreaming, designing, and delivering, and amplifying what is actually working in their communities and what they want to do more of and how they could do more of. The goal of the engagement is really to identify each community's unique needs, strengths, champions, and resources, and motivations to support the type 2 diabetes remission work. We identified common interests and synergies, and we really fostered a relationship building as an intrinsic way of motivating change. So you're kind of probably wondering at this point, what did this actually look like in our 2 communities in a 1-year project? It was a very short timeline to work with. And so really, when we started to talk about community-specific roadmaps, what the community came around were 4 main areas. They wanted to look at different nutrition and lifestyle interventions, such as community kitchens, physical activity groups, diabetes groups, what opportunities there was for education and outreach to their community. And I'll give a couple of specific examples of those in just a minute. They also wanted to look at the traditional and cultural approaches to wellness beyond the disease model, but to look at a much broader sense of wellness. And then fourthly, in an area like diabetes, type 2 diabetes, we really needed to look at the food access and security aspects. And those included things like what's the role of a community garden or good food boxes for community members who are of need of them. So some specific examples that were worked on was one particular area that we were able to fund a small amount for was to have a point of care A1C screening tool in one of the local pharmacies in Tumbler Ridge, so that now patients have an easy way to access measurement of their A1C and to determine whether they have diabetes or not. The second was both communities actually, and this is just an illustration of the Port Alberni, is both communities actually organized community fairs. And this was really a gathering of many different service providers. We kind of collectively thought of it as the Christmas craft fair for diabetes, where we had all types of services and supports for people to just drop in and to get access to. That include retinopathy screening, A1C screening, medication reviews by local pharmacies, orthopedic assessments, and foot care, all on spot, and traditional healers. So it was a really nice way to kind of gather the community and work on providing such a comprehensive opportunity for community members. And then another example was in Tumbler Ridge, where we know that there's been some dinosaur activity. They really wanted to look at how the community could help support people, and using local restaurants as a way to endorse meal choices that would support their diabetes. So they would get the stamp of approval, and you can see the little logo that they're working on. So in terms of all of the work that we were doing, type 2 diabetes is an emerging area. And we learned that the concept and the language of type 2 diabetes remission was not received well by all collaborators. And we had to have, we had an open dialogue where we co-created language that recognized the historical trauma and the stigmatization that's associated with diabetes care, and food-based approaches. The second lesson that we learned was definitely the relational work is the work. So trusted community leaders, whether they be a local physician champion or the local coordinator, are needed to engage the broader community in a meaningful way, as they held the initial respect and the trust of the partners and collaborators to establish the groundwork for shared success. And 3, when partnering with a community, it is imperative to leave a tangible project legacy behind, one that's meaningful to the community members who invested time and energy in a vision, something more concrete than simply, having successful community engagement. In terms of our future directions, now that our 1-year project is finished, it was so inspiring to see that all the community partnership tables have agreed to continue to meet to enableize how to continue the implementation of the various supports and services. A steering committee has been created to guide a second phase of this work. And we have received a shared care grant to be able to support the physician time for this. We're developing a toolkit to help other communities plan their own type 2 diabetes remission services and support. And we're continuing to look to future proposals for this type of work. And here are our contacts if anybody would like to reach out to with any further questions or comments.
Amazing. Thanks, Allison. Such great work. Maybe we have time for one question. And wondering, I don't see anything in the chat. Does anyone want to ask about this presentation? Maybe, Allison, I was just wondering, two quick things. How did you identify these 2 communities? And you mentioned the legacy impact, and I love the stamp of approval. Can you mention for Tumbler Ridge and the other community, Port Alberni, what the legacy impacts were? Are you still working on that?
Yeah, we're definitely. So your first question was
identification of communities.
Yeah. So with the Rural Coordination Center, we simply put out a call. We were approached by the Institute for Personalized Therapeutic Nutrition to say, hey, would you guys be interested in kind of partnering with us on this? And could you help us reach out to some physicians that might be of interest? And so we put it out to our network, and we had Dr. Ian Warbrick from Port Alberni and Dr. Claire Lenovelle from Tumbler Ridge, who were saying, I want to create a different narrative for my patients. I want to create a different impact for my community, and I want to engage in this to really kind of create a story of hope for patients where it's not where there is a chance to think about coming off medications or reducing medications, so on and so forth. So it really is about that community local leadership in terms of creating that initial place for to kind of move forward in.
Yeah.
And then in terms of the legacy piece, you know, with these kinds of funding, it is challenging because some of these are not for implementation, but we were very careful in terms of how we could do something for the community so that they felt like this was worth it. If I look at our Port Alberni as an example of what the legacy is, we came, like, there was lots of different providers all coming together, and it was Seabird Mobile Diabetes Clinic and the retinopathy and Island Health Diabetes and Nachalis Dietitian, and all of those people developing relationships. It creates a different level of engagement for their community going forward. So I think that would be part of the legacy, is just the relationship building and the ability to kind of know who's on that other side of the phone, so to speak.
Yeah, wonderful. Thanks so much. Great work. I'm very pleased to introduce our next speaker, Dr. Minnie Tang from the BC Centre for Disease Control. And the project will be on Emergency Services Registry, the pilot in Merritt. So over to you, Dr. Tang.
Hi, good morning, everybody. Can you hear me okay and see my screen?
Yes, you are all good for me.
Okay, great. Oh, whoops, sorry, I will need to, I was testing earlier and went to the bottom of the slides, sorry. Okay. Okay, sorry about that. Good morning, everybody. My name is Minnie Tang. I'm a first-year public health resident, and today I'll be presenting on the Emergency Services Registry pilot project that we have been working on at the BC Centre for Disease Control. And I want to acknowledge that the project is based in Merritt, which is on the traditional and ancestral and unceded territory of the Inga Klubna and the Selks people. Some background to the project. Last year, we presented also at the same meeting, but we'll expand on the work that we have been working on in the past year. So Merritt is a town nestled between Kamloops and Hope. And in the year of 2021, there was the unprecedented heat dome with the fire in Lytton, if you remember, if you're in BC at that time. And that was followed by a devastating flood that evacuated the entire city of Merritt. And this is the picture I took when I was in Merritt last year. And you can see that the river bank has really changed from the large flood, the atmospheric river that happened. The entire river course has changed. And more pictures that I took when I was there from highways that were just destroyed. So the pilot project is based on the Ministry of Health's initiative that is called the PERC project, which stands for Population Environmental Risk Characteristic. And this project aims to identify folks who are susceptible to climate emergencies because of risk factors such as living close to, for example, floodplains, etc. So that is what the Ministry of Health has been working on. And the project is led by Dr. Sarah Henderson and Dr. David McVie at BC Centre for Disease Control. And we're trying to answer two questions with our project. So first, can we use administrative health data to accurately identify people who could benefit from direct outreach before and during climate emergencies? And if so, how can we verify that this potential outreach is beneficial for residents in Merritt? Before going to registries, I want to acknowledge the his historical context of registries in Canada. As many of us are aware, registries have not always been used with the best intentions, especially in the Indigenous context, where lists were created to take children away into separate families. So there has to be reciprocity and cultural safety throughout the process of developing this pilot project. And questions such as who would have access to the list of names, what would people do with this list? So this requires a lot of trust, and I think you can imagine the level of confidentiality and privacy that will go into this work. So we are considering through every step of the process our positionality as we approach the project. So an example from Jasper, as you might recall from just this past summer, Jasper had wildfires that required evacuation of the entire town. And they established a vulnerable persons registry in 2021. And this is the first year that they've used it. So I've been in contact with Brooke, their VPR coordinator, and this is, they've been using that for repatriating their residents. So I did a jurisdictional scan of similar registries in Canada. They're often referred to as Vulnerable Persons Registry, VPRs. The first one was established in Sault Ste. Marie in Ontario in 2011, and they have about 452 individuals on the list. And it's a big table, so I'll just focus on enrollment, which you can see they're all based on self-enrollment. And then also at the bottom here, validation, they're all based on anecdotal evidence. This is the same for Jasper because prior to this year, they haven't deployed their VPRs. And Merritt as a region is not just the city. We're looking at the whole Merritt CHSA. From the flood in 2021, there was an increased mortality, as you can see, during that period. And that's why we wanted to work on this project, to work on a similar registry for Merritt. But in our context, we are moving away from using the word vulnerable because it could be stigmatizing. So we're using the word susceptibility and susceptible to build our registry. And before we dive into how we use data to develop our algorithms, we worked on community engagement to see if Merritt is a good place for this to work as a pilot project. So in Merritt, Mayor Mike's granddaughter passed away in a car crash that happened when their family was evacuating from the flood in 2021. Many people are still displaced and separated from their family members to this day from the 2021 flood. So I went to Merritt last year and spoke with Indigenous groups, including health directors from bands from Merritt to Lytton. Also talked to different institutions like assisted living facilities, Division of Family Practice, Ministry of Health, and mental health and substance use networks. Talked to nonprofit health services, and also their shelter support society, different responder services, including the police, ambulance, and fire departments, and then lastly, talk to the mayor and the city council. And we asked them this question: who needed more help during climate emergencies, especially during the evacuations from 2021? And this is the list of individuals that fit the criteria that's what we heard. So the elderly, people who don't drive, people with disabilities, people who are worried about looting, no access to phones or computers, poverty, having mental health challenges, no fixed address, on oxygen, etc. So these were the factors that we heard. And so an update since last year was us testing methods to identify susceptible people. Every individual faces a unique combination of risk factors and susceptibilities when it comes to climate emergencies. So we have built in different algorithm weights to identify these variations. For example, a person could be of older age, have mobility challenges. Another person could fit maybe all of these criteria, then they would be at higher risk. So what we aim to do is actually to identify the overlap in this Venn diagram, because that would give us more validation that this person is truly at risk. The data sets we have access to include the MSP data, pharmacare, chronic disease registries, home care, long-term care data, and ambulatory care system data. So we have access to Ministry of Health level administrative data for building these algorithms. This is a overview of Merit residents and risk factors. For example, the total proportion of Merit CHSA region is 16,000 people, and of the 16,000 people, how many, this is just proportionate, and people could be overlapping. So these are the proportion of people who fit these different challenges. And I want to show you different algorithms that we have built and how they differ. So for example, algorithm A captures people that, captures a total of 164 people, whereas algorithm B captured a total of 213, and a lot more people who are older were captured, people with more mobility challenges were captured, and people with housing challenges were captured more in algorithm B. So we're actually more interested in the overlap between the different algorithms. And this is a manageable number of people that can be evacuated ahead of time before we evacuate folks who are healthy and don't need additional support with evacuation beyond what's necessary in general. So for algorithm A and B, from a graphical perspective, look different in this way. I want to show you, this is the City of Mayor's map, and you can see that there are some differences. For example, algorithm B captured a lot more people in the floodplain area. This is where a lot of the flood happened in 2021. In this, I don't know if you can see my arrow here, but the 510 area. And then algorithm A didn't capture that. So we're really interested in the overlap between these two algorithms. And we have 14 algorithms in total. So the overlap between all of that is crucial for our internal validation. From a larger map perspective, this is the entire Merit CHSA, and you can see more differences between algorithm A and B. So our next steps would include more internal validation with the access to data that we have. And we're working with the BC provincial ethics team on privacy and confidentiality aspects, because as you know, most of these VPR registries are opt-in so that people enroll themselves. But we're thinking of a combination of an opt-in and opt-out so that people with cognitive impairments, for example, or people who are not aware of the supports that they might need, will get the support that they need. We'll also work on external validation, where I'll be going to Merit next year to validate the names of people by working with healthcare providers in Merit in Interior Health and First Nations Health Authority. And these are just some of the pictures that I took when I was in Merit with the mayor and Alana and her mom, who very kindly introduced me to the Indigenous health directors in the different bands around Merit. Yeah, so that's the presentation. Oh, sorry,
Great, thank you.
yeah.
Go ahead.
Oh, just extra slides in case I get questions about algorithms, but
Okay.
yeah.
Yeah, that's great. Great presentation. And really novel, and I learned a number of new things as well from this. So this is amazing. Do we have any questions for Dr. Tang? Maybe a quick one about the self-enrollment. How are people offered that, and how does the trust and relationship get built?
So in terms of self-enrollment, in other jurisdictions where they have rolled this out, they often just have a website where people sign up, or they sign up for their parents or their people they're caring for. And so if it's self-enrollment, for example, in Jasper, that's what they did, then these people will be contacted during emergencies, and they have an aggregate data with the kind of supports that they need. For example, they need wheelchair access, etc. For what we're trying to do, we're do a combination of that. So people who self-identify and also people who might not be aware of their needs, because if you remember the mortality spike during the flood, a lot of that were from folks with cognitive impairment living alone. So we want to capture those folks through our opt-out model. So we'll identify them, and then of course we'll let them know that you've been identified if you want to stay on the list, and it will be a process that we will go through, because as you can see, it can be a touchy subject with opt-out.
Great. Thank you. Thank you so much. You have a question about the algorithms, and just in nature of time, I'm wondering if you could maybe respond through the Q&A chat about access to that in the process of going through that. And we'll move on to the last presenter before the break. And we will now hear from Brian Martin with UBCO and the Implementation Science and Isolated Communities Lab, with a presentation titled Virtual Health Innovations Implemented in Rural and Remote Communities of BC. So, hi, Brian, over to you.
My slides. So thank you for dedicating the time to attend. This research project conducted by the Implementation Science and Isolated Communities Lab, based out of the Southern Medical Program, has been investigating virtual health innovations implemented in rural and remote communities of British Columbia. And in this presentation, I'll provide an overview of our approach and findings. Before we begin, I would like to acknowledge that we are gathered today on the traditional, ancestral, and unceded territories of numerous First Nations peoples across the province and beyond. I'm grateful to live, learn, and recreate on the territories of the Ktunaxa, Syilx, Secwepemc, and Sinixt peoples. So starting with a bit of background, rural and remote communities experience disparities in health, and these health inequities are caused by numerous factors such as limited access to care and specialty resources. One solution is leveraging virtual health innovations to expand, improve, and support these services and care that these communities receive. Moreover, the effects of these innovations can be maximized through the application of implementation science, and this could ultimately lead to a reduction of health inequity in rural and remote communities. As there currently does not exist a comprehensive resource compiling these innovations, we aim to identify virtual health innovations that have been implemented in rural and remote communities of BC. To accomplish this, an environmental scan was conducted. Environmental scanning is an approach used to collect and synthesize existing information. This information is then available to inform decision-making and help shape future efforts. Both academic and grey literature sources were reviewed in this process. Peer-reviewed articles from 5 biomedical literature databases as part of a scoping review on virtual health research were investigated, and grey literature was obtained from 28 websites. These websites of health authorities, universities, research labs, rural health organizations, and virtual health organizations were included. A two-step approach was used to search grey literature. First, websites were manually browsed for eligible sources, and subsequently an advanced Google search strategy was used to identify additional sources from that website. General eligibility criteria required that the article, report, or website described, reflected, and/or evaluated a virtual health innovation used or implemented in rural and remote communities of BC. And specific criteria included the following definitions for virtual health innovations and rural and remote communities of BC. Virtual health innovations consisted of any technology, approach, or method that leverages digital tools or platforms to improve the delivery, accessibility, efficiency, quality of healthcare services remotely. And rural and remote communities were defined using the Rural Practice Subsidiary Agreement Communities list. To be eligible, the innovation must be implemented at least one rural or remote community. Eligible articles then underwent data extraction, and extracted data included the title, innovation, type, description, organization, setting, users, and the presence of partnership and reports of being evidence-based or informed. Innovations were classified as 1, telehealth and virtual care, 2, mobile and digital health tools, 3, education, training, and health information systems, and 4, culturally tailored and community-based programs. Settings were further classified as provincial, regional, or local, and users were classified as health professionals, patients, clients, or both. If reported, implementation information was extracted using the REAIM framework. This included the reach, effectiveness, adoption, implementation, and maintenance of the innovation. And gray literature sources also underwent evaluation using the Journal of the American Medical Association benchmark criteria. Quality of sources was assessed through the presence of 4 criteria, and that includes authorship, attribution, disclosure, and currency. Of the 6,186 sources of academic literature identified, 7 sources were included following full text screening of 464 articles. And for gray literature sources, a total of 671 sources were identified for full text screening. 127 of these sources were included. To provide a general overview of the innovations identified, I'll break down the innovations in terms of data extraction attributes. So 134 eligible articles identified 69 unique innovations, and innovations were often described in more than one article. The major outlier here is the RTDS pathways, which were described in approximately 20% of eligible articles. 35% of innovations indicated the involvement of partnership, and 10% were reported as being evidence-informed. 45% of innovations were implemented at a provincial level, meaning locations in multiple regions of the province, but not necessarily every rural and remote community of BC. 35% of innovations were implemented regionally throughout a health authority, for example, and approximately 10% were implemented locally. The remaining 10% of innovations existed solely in a virtual setting. 35% of innovations were used solely by health professionals, 25% were used solely by clients, and 45% were used by both professionals and clients. And finally, approximately 7% of innovations specifically focused on Indigenous health initiatives. So I wanted to highlight some examples of specific innovations that demonstrate the diversity of virtual health initiatives in rural and remote communities across the province. First, the popular real-time virtual support pathways, or RTDS pathways, and specifically the Child Health Advice in Real-Time Electronically pathway, also known as CHARLIE. This provincially available peer support pathway provides 24/7 access to specialized pediatric support for rural health professionals. Local initiatives such as Welltel Haida are also being leveraged. This evidence-based mobile and digital health tool links patients and professionals via text messaging to enhance chronic disease care in the Haida region. So further discussing these results, many diverse virtual health innovations were present in rural and remote communities of BC. They were largely identified in gray literature, which ranged widely in detail and quality. And this could be due to limitations with the academic literature review strategy or other possible explanations. And then finally, there was a lack of information available about the implementation, effectiveness, and sustainability of these innovations due to limited reporting. So to conclude, an opportunity exists to optimally enhance care and services by applying and exchanging knowledge related to the implementation, evaluation, and sustainment of these innovations. The findings of this research will be used to co-create a catalog of innovations for dissemination to communities, organizations, and individuals across BC. So thank you for listening to my presentation. I hope that it was intriguing. If anybody is seeking additional information about the project, I've included contact information below, and I am happy to answer any questions that audience members may have at this time.
Wonderful. Thanks so much. This was a great presentation. Open up for question. Please raise your hand or put anything in the chat or the Q&A. Brian, maybe I'll just ask a question here about I think it was interesting that the real-time virtual supports came up, and I'm wondering if there was any surprising findings from the work, besides, I think, the methodology of how this gleaned results. But yeah, I wanted to know if you found anything surprising or something you didn't anticipate from the work.
I think one thing that maybe surprised us was the overall number of innovations that we identified. I don't think we were expecting to identify approximately 70. So that was one surprising finding. I think another kind of interesting finding was the fact that most of our innovations were identified in gray literature. It is something that we want to go in further into discussion and look at a bit more, but it could possibly be due to how we did the academic literature review, because that was taken, I guess the sources of academic literature were part of as I said, a scoping review on virtual health research partnership. So the fact that partnership was included in the search strategy could have possibly decreased the number of results we found. Yeah, so that was interesting.
Yeah, that's great. Thank you.
Thank you.
Okay, I think there is a question here. Maybe I'll read it out to you. Thank you, Brian, for the wonderful presentation. I noticed that 35% of the innovations are developed in partnership. However, 25% of these are described as not being evidence-based. I'm very interested in understanding how you categorize partnership, as evidence-based or non-evidence-based.
So for partnership, I guess it was based on a specific definition that can't remember at this point, but it was in the involvement of kind of community members or individuals within positions in health administration. And I know there's a presentation later today. I think it might be the last presentation, and that is they are the ones that did the scoping review on virtual partnership and virtual health research. So they would be able to better answer that question, and it should come up in their presentation. And for evidence-based or informed, that one was mainly whether it was explicitly expressed as evidence-based or informed. So it's possible that maybe some innovations were evidence-based, but it wasn't expressed, and we couldn't really identify that.
That's a great teaser for the afternoon. Lots of presentations around drone and some of the rural virtual strategies. So yes, thank you for that.
Thank you.
Any other questions? So maybe what I'll do is we are going into the break and going to come back for the second part of the agenda starting at 11 o'clock. So I just wanted to thank all the presenters for sharing their wonderful work. It was such a variety, and I learned a number of things. Please connect through chat with the presenters or with the Rural Coordination Center BC for the Rural Health Exchange if you want to receive slides or any links to the participants or the presenters. And I just want to thank everyone for joining the first part, and please stay tuned for the second. We're just going to have a short break, so I'll invite everybody to come back at 11 a.m. for the second half. Thank you.
So this is a great opportunity to grab some water. We'll be back at 11 a.m. Dr. Frank Schumeyer will be the next facilitator to cover the next 8 presentations, rapid fire presentations. So thanks for joining us. Again, huge thanks to the Rural Coordination Center of BC and the Joint Standing Committee on Rural Issues, as well as Doctors of BC. Thanks to Dr. Brenna Lynn, our initial facilitator from UBC CPD. Yeah, again, grab some water and hang tight. We'll be back at 11 a.m. sharp with a presentation by Dr. Doug Andrusek.
Hello, everybody. My name is Frank Schermeyer. I'm an emergency physician at St. Paul's Hospital in Vancouver, and I am the research director for the UBC Department of Emergency Medicine. For a long time, I've worked with RCCBC in facilitating this day here. I'm also an RTVS 811 physician, so I have lots of I talk to lots of patients all across British Columbia, and sometimes physicians if I'm going to send people to the emergency department. So I'm not just your typical urban physician who doesn't quite know what's going on in other areas of British Columbia. So we have some really outstanding presentations coming up, including some tremendous technological innovations. So I'm going to start off by introducing Dr. Doug Andrusiak. Welcome back to British Columbia, Doug.
Thanks, Frank. Just let me. Okay, thanks, Frank. So today we're going to not talk about innovation or anything qualitative, but we're just going to I'm going to give a little bit of a primer on using some of the data resources that are available in the province, specifically the Health Data Platform, Health Data Platform BC. I have no conflicts of interest. I'm not being paid by Health Data Platform, but I have a profound interest in quantitative research. And by the end of this, I will have described the Health Data Platform, types of questions it can answer, describe considerations for your study, which is quite important if you're going to use these sorts of data, and provide 2 examples of work that's currently underway. So the Health Data Platform, what is it? It's a secure cloud-based environment for conducting quantitative research. It contains registry data, including things like cancer registry, perinatal registry, renal registry. It has health administrative data contained in it, with the discharge abstract database, MSP billing, and PharmaNet. And it also contains population level data. So it has the population estimates that are produced by the province of British Columbia in collaboration with the federal government through Census Canada, and then some methodologies for adjusting your data set to be able to answer questions. The Health Data Platform BC is a provincial government Ministry of Health resource that's available for organizations to conduct research. And by what I mean by that is folks who work for, say, a health authority or a hospital, physicians or administrative people. These data are available for you. And what that means is that the application process is a little more streamlined and costs are quite a bit lower, generally free for folks who want to use these data. And the reason I raise those issues, because there's a bigger sibling in this province called Population Data BC, which is also available for folks to do research. And it's primarily an academic platform. The Health Data Platform differs from Population Data because it's hosted virtually. You do your work within a virtual environment, and your data doesn't leave that environment. You use the tools that are available to you in that environment and do that work in that environment. It also is not curated in the same way that the Population Data BC data is curated. And that means you need to assemble a different sort of research team to be able to come to a data set that you can actually do your analysis with. And the other great thing about Pop Data BC is that you can bring your own data in, and I'll be talking about an example that I'm engaged in a little later in this presentation. So given that the Health Data Platform BC contains all these great data sets, these clinical, administrative health system, and population data sets, it's an ideal resource for answering system level quantitative questions. Some examples are things like, or areas that you can focus on are things like identifying gaps in care for registry patients or clinical patients, examine disparities at a geographic level, and your geographic level can be as broad as rural versus urban and remote, or you can look at different health authorities or different health service delivery areas within a health authority. You have access to system level quality improvement, and you can ask questions focused on system level quality improvement. And you can conduct comparative analyses of the various geographies, as I've noted, including things like electoral districts. What this great resource is, it's a bunch of data, and for many of us, having a bunch of data actually can be quite intimidating. I'm sad to note that this grade 8 picture of me, I didn't become the president of the math club, but don't regret or don't worry, I can still help you through this process. So you need to think a little differently when you're doing data analysis or working with something like Health Data Platform BC. And the first piece of advice I would give is to engage an epidemiologist or a biostatistician. Basically, you need someone who's comfortable and capable of working with large amounts of data to answer quantitative questions. It's a good idea to consult with your epi or statistician early so they can help you develop your question. And once you have your question, they will help you identify what data you're going to need to answer that question, whether you need to bring something new in or how you're going to have to change that data. The data environment itself provides some analytic software. The two pieces of software are RStudio and SAS. And most statisticians or epidemiologists can work in either one of those, but you want to be certain that they can work in those, or you may need to add somebody else to your program. Aside from actually working with the data, there's another step that you need to consider when working with Health Data Platform, and that is actually managing the data. So there's the analytic end, and then there's the management of the data. Because data is not curated, meaning you don't issue a proposal and then have somebody put together a data set for you. You actually have to create a data set, an analytic data set that you would then go and use and analyze. So this data management, data science set of skills are very different and don't always overlap with an epidemiologist or a biostatistician. So you want to be certain that you've got somebody on your team who's able to do that sort of work. You can always work with your epidemiologist or biostatistician to be able to identify that person. And as you're going out and hunting for them, you want to be certain they can work in SQL, Python, or RStudio. The Health Data Platform is relatively new. It's often mistaken for Pop Data BC, but as I've identified, it actually operates in a very different way. And because of the differences and the lack of clarity for some folks, ethics boards often don't understand what it is. So these are some of the things you want to be very explicit about when you are putting together your ethics application and your application for access to the data. So Health Data Platform, or rather ethics boards are generally interested in the pure ethics of your research. Is it appropriate? Are you focusing on disadvantaged people? But they also worry about things like privacy. And privacy generally focuses on 5 areas, and these 5, they're called the 5 safes. And these are, do you have a safe project? Meaning, is the project appropriate, or is it going to do something that may undermine agency of certain groups or populations? Do you have safe people working as part of your team? Is your data analysis and data storage being conducted within a safe setting? You want to minimize unauthorized disclosure or release of the data accessed by people who are not authorized to see it. Is the data itself safe? Meaning, have identifiers been removed to minimize disclosure or identification of people? And is the output of your research safe, meaning that they're not going to be used to be able to identify people? And these 4 latter areas, safe people, safe settings, and safe data and safe outputs, are something that Health Data Platform actually is particularly well designed to provide. And then the safe project is something that you'll focus on when you're putting together your project itself. And so now what I want to do is just talk about a couple of projects I'm involved to give you a sense of the sorts of things that you can do with the Health Data Platform. So the first project is, it's going to be talked about a little later in this session. It's an examination of adherence to the Society of Obstetricians and Gynecologists guidelines for progesterone prevention of preterm birth. This was originally a Island Health Physician Quality Improvement Project, wherein Doctors Kask and Duckett sought to improve adherence to these guidelines to reduce the risk of preterm birth in their area up in Campbell River. The risk factors are easy to identify, and as part of the Physician Quality Improvement Project, they requested a special authorization, which paid for the costs associated with the prescription for progesterone. Doctors Kask and Duckett are now interested in establishing if their quality improvement project had any effect. So they recognize that their findings may be of interest to a larger community. So they sought out some assistance from me. The Health Data Platform houses perinatal registry data and PharmaNet data, and through that we can identify pregnant moms, we can identify people's prescriptions, and we were also able to identify or locate data within Island Health, which is required for us identifying the women who are at risk. So the perinatal data identifies women who had a previous preterm birth, which is one of the risk factors. And then there's another risk factor that's identifiable on ultrasound, and we've been able to identify those ultrasound reports from Island Health, and we'll be importing those into the data set. As a result of doing the project through Health Data Platform, we've avoided having to go out and extract data or abstract data from medical records, which is really helpful. It reduces error there, speeds up the system, and makes this study quite a bit less expensive than you would do if you had to do all that extraction. And so I think this is a really good example of the sorts of things you can do with Health Data Platform BC data. The second project is a project examining incidence of small bowel neuroendocrine tumors across the BC Northern Health Authority. And in this case, I was approached by a medical student, a flex student who was looking for some assistance on this project. Dr. Erin Martin is the general surgeon in Northern Health. She noted that there were a large number of these tumors in her practice. And so she wanted to find out if there was a higher rate or higher incidence of the tumors in the population in the north. So we're going to use data available from Health Data Platform to examine the variation in incidence, population incidence of this specific tumor in the north if compared to the other health authorities. And so there you have it. It's a great repository, Health Data Platform BC. It gives you access to clinical, administrative, health system population data. You need to do a little bit of thinking ahead of time and identify some expertise, specifically a biostatistician or an epidemiologist who can be of assistance, and maybe even somebody to do your data wrangling. But the time and cost savings are likely to be quite substantial, which is always a good thing when doing this sort of research. And so there's my contact information, and I'll leave it there for any questions.
Right, everybody. Thanks, Dr. Andrusiak, for a great presentation, saying what's kind of possible now in British Columbia. Obviously, governments have been working more towards this for a long time. Just looking at the chat here. This is more of a comment from Dr. Sonia Cressman, who'll be talking later. Thank you for such a great overview of HDP and the ways we can mobilize these data. I love your point about working biostatisticians and epidemiologists, incredibly important, probably necessary to be working with R and SAS in the secure research environment. I'm an economist. Okay, fair enough. And then another complimentary thing. So from a logistics point of view, Doug, let's say I am a resident or a physician and I've got a great idea for something I'm seeing in my practice. How do I engage a statistician, preferably with experience in obtaining data and wrangling data and analyzing data in the format it's given? Keep in mind, these aren't all going to be in beautiful Excel spreadsheets, so a novice can work on them. Some of the stuff's quite complicated, and doing the data linkages can be difficult. How do you even track down somebody who's going to be good at this and can give you the practical advice that will make the difference between success and non-success?
So, my first piece of advice would be to make it rural and then just come ask me. So there's resources. So my position at RCCBC Island Health affords me the opportunity to consult right at the outset. So somebody who has, and I've dealt with probably about 40 projects in the year, everything from qualitative to quantitative, and the conversations are wide and varied. So I'm available as a resource. The School of Population and Public Health would be a resource one could also reach out to at UBC. And then if you're in one of the facilities, say in the city, that's associated with, say, Vancouver Coastal or at Fraser or any of the other health authorities, these have research programs embedded in the health authority. And generally there will be a research at Island Health or Interior Health email that you can just pose your question, and you should be able to get like a half-hour, 1 hour consult where someone will sit down with you, identify your question, and then start working with you to frame up your work.
Excellent. And Dr. Cressman actually had a question in that paragraph there. Will STATA be offered in the HDP secure research environment?
Actually, Sonia, I don't believe it is. They've only recently added SAS or SAS rather. The same as you, I don't generally work in R or SAS, so it's always a bit of a strain for me. I'd love for them to put SPSS in it, but this is sort of what we do. Hopefully, if we press them and tell them that those are not the only software packages that people use, then maybe they'll consider paying for licenses for the other ones.
Sounds like excellent news. And we're going to move on to Dr. Audrey Warner after this.
Good morning, everyone. I'm not a doctor, just to clarify. Thank you so much for joining today. My name's Audrey, and I'm a Master of Public Health student at UBC. I'm really grateful to be part of the BC Rural Health Research Exchange, so thanks to all the organizers of this event. Today, I'm going to be sharing my work within the Drone Transport Initiative. Before I begin, I'd like to acknowledge that I'm presenting from the traditional, ancestral, and stolen territory of the Musqueam, Squamish, and Tsleil-Waututh people, colonially known as Vancouver. Not only is it important to acknowledge that I'm an uninvited guest, but it's also important to recognize the inherent rights of Indigenous people that stretch across every inch of this province. I would like to express gratitude to the Tsilaten First Nation for their role in co-creating this work, and also to the Notley-Wuten First Nation upon whose lands the village of Fraser Lake is situated. So rural, remote, and First Nation communities experience unique barriers to healthcare access situated at the intersection of geographical inequities and historical contemporary harms of colonization. The COVID-19 pandemic shed light on critical healthcare access gaps, both in terms of access to healthcare providers and access to medical supplies and diagnostic testing. Lockdowns and supply chain disruptions highlighted a critical need to improve healthcare access in these communities. While telehealth can support access to healthcare providers, access to diagnostic testing and medical supplies requires different solutions. So it was within this context that the Drone Transport Initiative was conceived. Built upon the foundation of a decades-long relationship between the Tsilaten First Nation and Dr. John Polovich, a family physician, and the village of Fraser Lake, there was a unique opportunity to explore the feasibility of using drones to transport medical supplies. This project took place in October 2021 in the host communities of Steilaco and Fraser Lake, which are in northern BC, about 150 kilometers west of Prince George. The Drone Transport Initiative started as a 12-month demonstration project to investigate the feasibility of using drones to transport medical supplies in a rural context. A drone flew between the village of Fraser Lake and the Tsilaten First Nation, a distance of 5 kilometers and about a 7-minute flight. The initial scope of the project was to transport mock medical supplies by drone, but the project evolved midway to transport real medications. The goal of this study was to explore the experiences and perceptions of people involved in phase 1 of the Drone Transport Initiative to guide project implementation and expansion in future phases. At the end of phase 1, semi-structured interviews were conducted with 20 participants who were involved in the project, both at the oversight level and the operational level. I did a thematic analysis of interview data using an inductive approach and followed Braun and Clark's iterative process. I was really aware of my positionality as a white settler, having been trained in these Western systems of education and not having been part of phase 1. But in this way, my position as an outsider was an opportunity to generate themes from a naive perspective. However, to ensure the analysis still reflected community perspectives, I shared back my preliminary results with community co-authors to incorporate essential insight and context to the findings. The result of this analysis was 4 themes, and because the study is pragmatic and will inform future phases of the work, we organized each theme into processes and outcomes, where processes are steps or activities to achieve an outcome, and the outcomes are the results of these processes. So this is a high-level overview of the 4 themes that we generated from the data. The first is about respectful and trusting relationships. The second is about achieving mutual benefits in working partnerships. The third is about meaningful engagement with communities. And the fourth is about the drone project being the first step of something big. A common thread within these themes is the emphasis on the relational aspects. For the sake of time, we're just going to look at themes 3 and 4. The third theme explores the importance of meaningful community engagement in helping the drone innovation project become embedded into community. Our main process within this theme was the continuous engagement of community members in ways that are guided by community protocols and liaisons. And our main outcome is community acceptance and ownership of the project. Community engagement was a big part of the drone project and involved open houses, informal conversations with community members, and also social media engagement. Taking a holistic approach, the project recognized that everyone would be affected by the drone's presence in the community, whether or not they were using the drone services. Also, there were several school visits to the drone site and other youth engagement initiatives where kids had the opportunity to learn about the drone and get excited. The goal of the community engagement was to promote community acceptance and ownership. The last quote here shows that community acceptance may be viewed as an important prerequisite, not just a nice idea, but something that must be established to allow the project to go ahead. Especially in a First Nation context where there is a harmful and exploitative legacy of research, community engagement was not just an extra activity, but a real priority within the DTI project. The next and final theme I'd like to discuss is about understanding how participants envision the future of this project and the diverse uses of drones in a rural context. We're going to look at what makes this first phase of the drone transport initiative really the first step of something big. Our main process here involves maintaining the vision during phase 1 of the project. Because it was a demonstration and involved a proof of concept, it required imagination and the ability to cultivate an understanding of the goals of the DTI. With that, the outcomes for this theme are being able to envision the future of this work, with the notion that perceptions of progress are shaped by the diverse lived experiences within the project. The project really required people to think about the future and was facilitated by leadership within the DTI. The ability to communicate the vision was an important part of ensuring that members of the operational team really understood the bigger picture of what the drone project was trying to accomplish and help staff stay motivated. The short drone route may have made participants feel like it wasn't filling a real need for medication delivery, but in reality, it did make a big difference in allowing community members to remain at home. The short drone route in the early stages of the project also prevented compromises to patient care in the case of complications with the drone. In addition to the drone's potential within healthcare, participants shared diverse ideas for how the drone could support rural, remote, and Indigenous communities in other areas, from environmental monitoring to natural resource exploration and disaster recovery. So this analysis uncovered several important conclusions. First, the importance of building trusting relationships between communities and partner organizations. Second, the relational foundation that is necessary to implement and sustain drone innovation projects in rural and First Nation communities. And finally, the potential for drones to be used by communities according to their distinct priorities. The study contributes to existing drone literature by focusing on relational and social components of drone work. While studies demonstrate that drones can and do deliver healthcare supplies, what was less well understood was the nature of the human capital and relationships required to sustain a community drone project. So this project makes an important contribution in its focus on relationships. So currently we're in the development stage of phase 2, and these learnings will guide our approach to future phases. From a community perspective, this project also demonstrates a real commitment to healthcare innovations that consider rural and First Nation communities first, and puts these communities at the forefront of innovation. In addition, the project contributes to provincial and institutional obligations toward truth and reconciliation. These findings demonstrate the promising potential of using drones to address health inequities in the transport of medical supplies to rural and First Nation communities via drone in BC. The relational aspect of this project is central and shows that this project really is much bigger than the drone. So thanks to you all for listening. And before I take questions, I'd like to acknowledge all of our co-authors and partners for this project, my supervisors, Dr. Femke Hoekstra and Sandy Lee. And in particular, I'd like to acknowledge the Stillatin First Nation and the village of Fraser Lake for their tremendous efforts, leadership, and collaboration in co-creating this project. If you'd like to keep up to date with the DTI, you can visit our website at dronetransport.med.ubc.ca or email dti.info@ubc.ca. Thank you.
Excellent. So here's a question from Megan B. Do you know what the cost of a drone flight was compared to driving or a transport flight?
That's a great question. And I'm not really sure that I can totally answer that because of the grant funding that was associated with the project. There are a lot of sort of costs that are included in a drone flight. But I could definitely follow up with you by email if you'd like to know more.
There's another part that this was split up as two from the same person. Do you know what the range of the drones were or what the drones themselves cost?
The range of the drones?
Yeah.
So this was the drone was leased for a period of 1 year. We secured the drone technology, so we didn't actually own the drone. But yeah, I can understand that there are a lot of questions about the costs of that, but that was not particularly a big part of my involvement in the research. So I'm sorry, I don't have the answer to that question.
I'm gonna jump. There's a question in the Q&A for you to answer later on, and I see Dr. Cressman has her hand up. I'm just going to go into the cost bit one. Actually, I'll let Dr. Cressman speak.
Hi, I am an economist and I've worked with Sandy Lee in the sense of kind of charting out what the cost would be for the drone transport project. So I'm so excited that this question came up and I wanted to offer the chance to connect offline when we've got more time about this. We want to think about what we're saving in terms of road travel, also what patients pay when they don't need to do that travel themselves and pay for that out of their own pockets and with their own time. So it is a really cool question. And I'm very excited to work with you if you'd like to on that in the future.
Question for me here. How do drones operate in bad weather?
That's a great question. So there are definitely weather restrictions. The drone was only able to fly under certain conditions. And so if it was too hot or too cold, the flight may have had to be canceled. However, the drone was able to fly in a lot of conditions, and it can operate in day or night and under weather conditions that include moderate rain, snow, and wind.
Alrighty, excellent. Are there, like I said, there's one question in the Q&A which you may.
Oh, sorry.
It's a bit longer, and you can this is the kind of thing you can probably fill out on your own time afterwards. The other presenters have typed an answer in afterwards, even though it's an important question. It's just going to take quite a long time to answer, and we only have a minute left here. So.
Okay. Yeah, I can definitely follow up with that question after.
Excellent.
But, thank you very much for the opportunity to present here.
Alrighty, and now the second part of the drone presentation is Dr. Kimia Nuhi. I hope I'm pronouncing that okay.
Hi, thank you so much. Also like to mention that I'm not a doctor. I'm just the project coordinator on the same project that Audrey just presented on. I'll just be sharing my screen here. And I'd like to confirm that everybody can see my first slide.
Yes, that looks great.
Perfect. So hi everyone, thank you for joining me today. My name is Kimia and I'm a project coordinator at the UBC Faculty of Medicine. I've really enjoyed all the other presentations we've had and I'm very excited to present my work as part of the Drone Transport Initiative at the BC Rural Health Research Exchange. As part of the Faculty of Medicine, we co-created a project with the Village of Fraser Lake and the Stellatan First Nation to operate a drone project with phase 1 being done over COVID-19. Today, I'll be presenting the barriers and facilitators of the project that we analyzed during phase 1. I wanted to take a moment to appreciate the Stellatan and Natalie-Wooten First Nations for inviting us to plan, implement, and execute this work on their territories. Also, I respectfully acknowledge that I live and work on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. As an immigrant who spent most of her life in Vancouver's urban areas, working on a rural project has been a privilege that has allowed me to see the gaps and opportunities in the healthcare system, giving me the purpose of helping with co-creating solutions for these communities. So as my colleague already spoke about the project context and background, I will only briefly review it. We know that BC's rural, remote, and Indigenous communities experience barriers to healthcare access that were exacerbated by the COVID-19 pandemic. The pandemic also allowed us to visualize these healthcare access gaps. While virtual care can bridge these gaps, other types of medical care require different solutions. This is how the Drone Transport Initiative, or the DTI, was conceived as an opportunity to co-create innovative, fit-for-purpose solutions for the Stellatan First Nation and the Village of Fraser Lake. The DTI was launched with funding from multiple funds and started in October 2021. This 12-month project used a drone to transport medical supplies over a 5-kilometer route between Fraser Lake and the Stellatan First Nation, a 7-minute flight approximately 150 kilometers west of Prince George. Here is a map of the project location. This project was initially focused on mock medical supplies, and it soon began delivering real medications, especially valuable during COVID-19 lockdowns. By mid-project, pharmacy delivery was added, with ground delivery as a backup. At the end of phase 1, interviews were conducted with the steering committee and the operational team to assess project outcomes. So what were the objectives using this interview data? Being a longitudinal 12-month project, the phase 1 of the DTI presented unique barriers and facilitators. By identifying these from project evaluation interviews, we hope to form key takeaways for future health technology projects, which will be written in the form of a playbook. As previously mentioned, interviews with members of the steering committee and operational team were conducted by the project manager at the end of phase 1. Participants represented diverse groups, including the Stellatan First Nation, the Village of Fraser Lake, and other health system partners such as Carrier Sekani Family Services and the drone provider Drone Delivery Canada. The interviews were 20 to 60 minutes each and varied from individual to small groups. My role was to conduct a barrier and facilitator analysis using the interview data, where I coded the data using NVivo 14 using a deductive approach. I developed a codebook by analyzing the transcripts and creating relevant subcategories within the PESTEL framework, which stands for political, economical, social, technological, environmental, and legal factors. Each quote from the transcripts was classified as either a barrier and facilitator, and ongoing revisions and recategorization were made after discussions with the co-authors to ensure that we're reflecting the community perspectives. Here, I'd also like to acknowledge my positionality, not having been a part of phase 1. However, for me, this was an opportunity to create subcategories from a naive perspective without having been influenced by prior participation in the project. So this is an example of what our final codebook looked like, where we have the 6 PESTEL categories up top and the relevant subcategories that we created underneath each one. The brackets with BF and B/F indicate whether the quotes represented barriers, facilitators, or both. And in the interest of time, I will only present a few social quotes. So I'd like to now highlight some of our results, which are split into the steering committee and operational related findings. First up, we have the steering committee quotes, which showed us how external factors influence relationships with communities, healthcare providers, and the government. Under the social category, we had lots of findings around the outcomes of high-quality relationships identified as facilitators. We found that engaged sponsors and partners and clear roles and responsibilities allow for the formation of positive relationships among the community, sponsors, partners, and the project team. This relates to the feedback that we received from Chief Robert of the Tsleil-Waututh Nation, who expressed that it was meaningful for the community to be involved in the project. He highlighted that this initiative allowed a rural remote community, typically not at the forefront of technological advancements, to take a leading role. It also provided an opportunity to bring various groups together, embodying a holistic approach to truth and reconciliation by allowing communities to guide solutions tailored to their specific needs. Next up, under the social category, specifically within the cultural safety and humility subcategory, we identified another facilitator. We found that building cultural awareness by leveraging training, past experiences, and insights gained from previous projects with Indigenous and First Nation communities helped with the current project. This approach not only aligns with TRC efforts by promoting engagement with communities and showing commitment to reconciliation, but also has improved relationships between the two communities who historically have not always had a strong connection. Moving on to our second set of results, which was under the operational team subset, and this was how external factors impacted day-to-day drone operations. Again, in the social category, we had a subcategory of role expectation and satisfaction, where key operational insights emerged regarding the experience of project workers. We found that delivering real medication rather than mock samples significantly increased job satisfaction among team members, as they found purpose in providing essential services to the community. This shift from mock to real deliveries not only motivated the workers by giving them meaningful work, but it also has a positive impact on other stakeholders, such as our community members. However, it's important to note that starting with mock samples helped us build competency and regulatory capacity, ensuring safe operations as the project transitions to delivering actual medication. Now for some of our key takeaways, I'd like to highlight 4 important points. First up, we have the importance and the centrality of social factors. In a project like this, relationships and trust are crucial. So we've chosen to center our PASTEL framework around social factors, where we emphasize the importance of collaboration and community engagement in our findings. And we do recognize that the social aspects ultimately had the greatest impact on the phase 1 of our project, and hence why co-creation with the community has been essential. Next up, we had community alignment, where respecting local policies, Indigenous governance, and cultural protocols enhanced our partnerships and fostered mutual respect. Next, we had economic empowerment. Hiring locally addressed capacity needs, fostered community ownership of the project, and supported long-term sustainability. Engaging youth through school presentations also empowered the community's future. Lastly, we had technological and regulatory adaptations, where we employed fit-for-purpose technology and adapted to local regulatory and environmental constraints, and this ensured functionality and compliance in rural settings. Engaging with communities early on also allowed us to effectively navigate these challenges. Now I'd like to tie it all together with a 2-minute video from phase 1 of the DTI to understand the community's perspective of the project.
Right from the outset, when the project was first announced and discussed, we started having it being a part of the community, having that medical device bring them their prescription.
The UBC Drone Transport Initiative is really a partnership project that embeds drone technology into the healthcare system.
In remote communities, the roads are not paved. There's hardly any traffic going in and out. And so a drone would Oh God, that would help so many people. Now I don't have to worry about getting my medicine. Now it comes to me.
The drone and a telehealth helps have community members stay at home. And that's a big thing. It provides that service that where they can come to a health center that they understand and see the doctor.
It was an ideal project to bring youth in and have youth engagement. We had a logo design contest. We also had a naming of the drone contest, and the drone name was called Sky Medic.
One other thing this project brought to the community was a sense of pride of being the first. First Nations communities in general are not very high on the list when it comes to medical technology. My hopes is that we are the launching pad going forward, and that we are kind of the main drone airport to supply other First Nations within our area.
There's so much more that can happen with further distances, with newer technology. It could really help rural and remote Indigenous and non-Indigenous communities.
They don't have to worry about their medication, or if something happens, they need the drone and it'll be right there. It's really awesome that, you know, this can get out to all different people.
So now I'd like to highlight some of our next steps. What we plan to do is to use these barriers and facilitators as a base for a playbook for other groups to co-create similar health technology projects with First Nation communities and to further inform our approach in subsequent steps. We're currently in the development stage of phase 2, and if you're interested in being involved, please feel free to contact us using our emails on this page. Thank you so much for your attention. Feel free to ask me any questions you have now or via email. Our website is also linked below, and you can scan the QR code to know more about our project. Thank you so much.
Right. Thank you very much. That was very, very well done, the two presentations combined. Are there any questions in the chat or in the Q&A? Okay, so here's mine. You did a great job, obviously, engaging with your first community. How do you engage your next one?
So we are currently still in touch with our First Nation community, and one thing that really allowed this project to go ahead was the pre-existing relationships of Dr. John with the community as he practiced in the community before this project even began. And so that really allowed the community to increase their acceptance of this project and engage their trust. And so in the future phases, we still hope to engage the community as we're currently in touch with them, and we're sharing back all of our results to ensure that their perspectives are heard in our presentations and in our papers. And so just by constant communication and updating them on what has been done and what we plan to do in future phases, we hope to still engage them and hopefully expand our reach to other First Nation communities who may have similar needs.
Yeah, that's the thing I'm more interested in, is how do you scale this project up, essentially, right? You've clearly proven it can work in one area where you already have pre-existing relationships. How do you move forward in other parts of the province, other areas where you might not have those pre-existing relationships?
Yeah, I think with that, there's a lot of research to be done on our side as the team, and to just engage with other rural physicians to see what other areas may need extra help, engage with other pharmacies, and just like more research on our side, I think would be really helpful, just to just know more about the gaps, and then also engage with our own First Nation community to see if they have any suggestions. Like I know Burns Lake might benefit from similar drone projects, and I'm sure there's a lot of other First Nation communities who will benefit, and we're always more than happy to respond to emails if they think that this is something they would like to be a part of. We're always happy to meet with them and see what we can do to help.
I'm almost thinking that the partners in the initial First Nations community would also manage to reach out to other communities. I mean, once word of mouth or social media spreads that this is a very cool project, I'm getting the feeling other people might want to be involved.
I definitely agree.
That video was really well done, by the way.
Yeah, every time I watch it, I also get emotional. It's really meaningful to me.
All right, well, okay, oops, here's a last question here. Do you know of any costing questions asked from the previous presentation?
So the cost of a drone flight?
Any of the costing questions, the cost of a drone flight, the cost is compared with conventional transport or non-drone transport?
So as far as I'm aware, the cost of the phase one of the drone transport initiative, it was lower than transferring by roads, just because there's not always accessible roads in that area, and arranging for either a taxi or transportation is expensive and quite time consuming. And so the cost of the drone were much less. However, in phase two, we plan to get a new drone, so to further decrease these costs and also on the environment. And so I don't fully have this information because, as I said, I wasn't part of phase one, but I will follow up with you, Megan, to give you a better idea of what the actual costs were.
Thank you. And a big hand from Dr. Cressman. Okay, we're going to switch from drones to another project that Dr. Andrusiak alluded to earlier on, and it's Doctors Jennifer Kask and Kirsten Duckett.
Yeah, thank you. Now, you guys are going to hear about a project in progress rather than one that's actually underway. And I hope that this is that you'll be able to see it. So I am here on the traditional territories of the Lakota people.
And I'm coming to you from the traditional and unceded territory of the Sauk Nation, part of the Coast Salish people.
So we're going to talk a bit about our project, which is around identifying the adherence to progesterone prescriptions in the prevention of preterm birth. So a bit of background, preterm birth is a birth that happens before 37 weeks of gestational age. It is the leading cause of neonatal morbidity and mortality in BC and worldwide. And because the last several weeks of newborn development is responsible for about 35% of brain growth as well as lung maturation, being born too soon is the underlying cause of a number of disabilities such as cerebral palsy, chronic lung disease, hearing loss, and blindness, and also school success, even if you're born close to term. And being born preterm is the underlying cause of 75% of newborn deaths and 80% of newborn illness. It's extremely stressful for families, disproportionately so, I would argue, for those from rural and remote sites who are affected by the impacts of transfer to higher level of care. And we've so eloquently heard about the impacts of remaining in a higher level of care setting as you're caring for a loved one who might be in an NICU. And of course, the NICU settings are often a significant distance from home for people in rural and remote communities. The Indigenous population has a preterm birth rate of more than double that of the rest of the BC population, according to the In Plain Sight report. And the preterm birth has been estimated to cost the Canadian healthcare system $8 billion a year. So Dr. Duckett and I had traveled together for remote medical visits to the tip of northern Vancouver Island for a number of years, recognizing the significantly higher preterm birth rate in this rural and remote population. And we developed a passion for prevention along the way and a quality improvement project. And now our research project is sort of growing out of this.
So we based our quality improvement project on guidelines, on national guidelines from the Society of Obstetricians and Gynecologists. They had a previous guideline in 2008 that suggested you could give progesterone to high-risk women, but they substantiated this recommendation in guidelines that came out in 2020 and recommended quite strongly that vaginal progesterone could be given to women at risk of preterm birth, which is essentially women who've had a previous preterm birth and people who have an identified short cervix at their anomaly scan in mid-pregnancy. And what's exciting about vaginal progesterone is that it is a low-tech intervention. These are tablets that pregnant people insert themselves into their vagina, and although a prescription is needed, it doesn't need to be a prescription provided by an obstetrician or a maternal fetal medicine specialist. This can be a prescription offered by a family doctor in the rural communities, and even in communities that are even more remote and rural without family doctors. Contact can be made with these virtual real-time helplines that were alluded to earlier, like Charlie, but the equivalent for perinatal problems is Mabel. So they can even be prescribed remotely to pharmacies where these people are living. They can be, it is a relatively expensive intervention, even though it's low tech, but it is covered by special authority prescription for exceptional circumstances in BC. Have the next slide. So our planned research study, which, as the others have said, have kind of stemmed from our quality improvement project, is a retrospective study with the objective to estimate the prevalence of vaginal progesterone prescription amongst pregnant people who have been identified as being at high risk for early birth. So again, this is people that have had a previous preterm delivery or have an identified short cervix on their anomaly scan. And this is a cervix that's less than 2.5 centimeters on ultrasound. And our hypothesis is that individuals who live in rural and remote locations are less likely to receive this important prescription. And what I should have said before is that the evidence shows that prescribing and using progesterone in this way, roughly from 16 weeks to near term, can reduce the chance of having a preterm birth by about 50%. So for a low-tech covered intervention, this is pretty important. Our methodology has been alluded to by Dr. Andrusak earlier. It's going to be a cohort study of all the pregnancies in Ireland Health between the dates of 2019 and 2024, which will cover just before the national guideline came out in 2020 and afterwards. And he more eloquently than I stated where we're going to get our data sources from, but from Health Data Platform, PharmaNet data, and from to do with the ultrasound from Ireland Health. We're then going to classify the people who delivered based on their area of residence according to the usual rural subsidy agreement locations, and then measure the association between their residential status and whether they got a progesterone prescription or not using logistical regression. We anticipate, or we hope to see whether there is a gap in perinatal care that could be closed and therefore reduce perinatal morbidity and mortality if more people complied with the SOTC guideline. And although we think that there may be deficit in rural care, it's possible that there's a deficit in care whether you live rurally or urbanly. There was one paper from 2018, so before this 2020 guideline in Ontario, that was just a small local medical record retrospective study. But of their 1,000 records that they looked at in both primary, secondary and tertiary care, and they identified the 30 or so women who were at high risk, less than 50% got prescribed, or less than 50% received an intervention that might have prevented them delivering early again.
So I feel strongly that living in a rural or remote location should not preclude receiving excellent care that includes care as recommended by Canadian guidelines and best practices. I've actually just returned from Australia, and in Western Australia, there's just the one tertiary care hospital, which took on an intentional program of risk reduction back in 2014 through 2018. And they reduced their preterm birth rate successfully, strategies that were then adopted in Australia nationally. And in the first 3 years of their Australian Preterm Birth Alliance, Australia's preterm birth rate actually was observed to decrease by 6.5%, which averted 1,700 preterm births a year and saved an estimated $90 million Australian dollars yearly. And they're expecting the final analysis to be coming out at the end of the year. So Australia is not the same as Canada, I recognize that, but there are some similarities in terms of our large geographies and an Indigenous population that have suffered health disparities because of health policies and colonization. So we look forward to coming up with or sort of carrying on with our research project. I am going to share this video that was made 2 years ago by Island Health and First Nations Health Authority. And I apologize that you're going to hear me talk about some of the same things I've just talked about, but it brings it back to why is this important?
Preterm birth is a birth before 37 weeks gestation, and it is the leading cause of perinatal morbidity and mortality on Vancouver Island, but also worldwide.
Losses in Indigenous communities is far greater than in the Western communities. What we're trying to understand is why.
Indigenous communities have suffered a legacy of health policies that have really caused trauma. And there's many health disparities, and we do see that with respect to preterm birth.
We need a lot of help in the way of education, in the way of sharing information, in the way of working more closely with the doctors, the midwives, understanding problems that may arise.
We're using this day as a recognition of excellent care of preterm newborns, of their families, but also it would be wonderful if we didn't see prematurity as much as we do right now. And that's really my goal, is that we recognize people have had this before and that we stop that cycle of having it again if we're able to.
You know, we're always looking for different ways to support mothers to prevent premature birth. And I think we're on the right track as we move forward in helping all of these young parents.
So just to close off, World Prematurity Day is celebrated every November 17th. And we developed a little challenge, preterm birth knowledge challenge. And so feel free to scan the QR code and take the challenge and see if you learn something today, test your knowledge. And we look forward to any support that people want to give some new researchers in this realm. And we've been super grateful to Doug for his help as well. So scan the QR code, and here is our last slide. It just has my email, but feel free to reach out to any of us. Thank you.
Thank you very much. That was very well done. A couple of really positive comments there from a number of people. Thank you very much. There's a long question in the Q&A, which from Jason Curran, which I'll let you answer on your own time. Question period is going to be pretty short here. Thank you for your important work. Has the Society of Obstetricians and Gynecologists reviewed the UK's recommendation for progesterone use for people with a history of pregnancy loss? If not, is the Society planning to review this recommendation? It's a question in the chat.
I do some work with the SOGC on guidelines, but I can't speak to whether they are going to look at that in the future or not.
Very well. And again, I encourage you to look at the thorough question, the Q&A. It may take you some time to answer that one. Obviously, a terrific project and one that's going to last for quite a while. Hopefully, have some hopefully have some promising results. So up next, we have Dr. William Clifford, who's going to talk about rural personal health records.
Hello, everyone.
I'm coming to you from the territories of the Lake-Wet'suwet'en people and the Wee-Way-Cum and the Wee-Way-Kai First Nations, same as the previous presenters. I'm here to talk about our rural personal health record project, which is sort of only can probably be loosely considered as research, but I think it's going to lead to a number of interesting research possibilities. We're here to talk about the what and the why, and also to just to emphasize that I'm just one member of a team. I've listed just some of the members that I work with on this. This collage here sort of shows a summary of our work to date, and it's through the voices from patients on our Patient Voices team. Looking at the challenges that they face, the patients face in achieving care, the opportunities that they see and we all see coming out or arriving out of personal health records, things like improved communication and improved safety and trust and so on and so forth. And it also speaks to the big challenges that are ahead of us with a digital health ecosystem being able to support this seamlessly at the same time that it supports all the other digital solutions that need to be interconnected. Now, just to say, the RPHR here is a double entendre, or triple entendre. It does mean rural, it does mean RCCBC, and it refers to personal health records. But it doesn't this is not about developing a rural personal health record. It's about how to pave a path forward, or at least identify how we might proceed effectively to use digital health for better care of patients, as well as patients feeling more empowered about their care. So the interesting thing about this project was that it started with sharing information. Essentially thinking of the personal health record as exactly just that, a personal health record, where information is delivered to the patient that can actually, by integrating some information that can help providers, patients can bring their personal health record to fill in the gaps of our fragmented healthcare information systems. Yeah, that would be great, but also for patients to be able to utilize the information themselves. So if this has been so well proven through projects like Open Notes, which has been going now for over a decade, and it's influenced the Harvard system and the Beth Deaconess Israel system in the US, where 10 years ago I watched a very impressive demonstration by their CMIO and Emerge Doc on how sharing notes can be very effective. And we even partnered for a little while with Open Notes about possibilities for research and collaborating on that. And then we all decided that, wait a minute, there's so much research on the value of sharing the information. Maybe we should just sort of figure out how we can actually deploy it. And if it was so great, why isn't it ubiquitous? Why hasn't it become like our mobile phone or like our use of emails? And so that leads you to start to muse about, well, has the content been lacking? Maybe there's not enough. Maybe there's not enough depth and breadth. Maybe the architecture of how personal health records have been deployed isn't up to what is needed. So this has led to the concepts of portal soup, as more and more of this is being deployed as portals. And it's even got a medical term now, polyportalitis, which I heard on the call with the Office of the National Coordinator in the US. Is there problems with the scope of function? Like, is it sharing the record enough? Is there more to all of this, a digital health solution for patients? And what would be those kinds of things that need to be addressed by a digital health solution to be very attractive and very effective? And then what are the barriers? And there are so many, there's question marks on the barriers, but they're not question marks anymore, I don't think, without even outside of our project. Provider or patient lack of demand is definitely an issue, especially with provider concerns. Gatekeeping of information has been an issue. A lack of interoperability is probably the biggest issue at the moment, and you'll see why in a bit. And then also, in the rural construct, poor digital connection and geography, legal issues, and even this excessive focus on privacy and security, not that they're really important, but it's been so much so that it's caused people to think that sharing information of the record might actually be illegal in some cases. And now, fortunately, we're talking about information blocking and reducing those barriers. So certainly the access to complete information matters. So by complete meaning, like I mentioned before, breaking down the fragmentation of the record, and additionally being able to help patients interpret their information prior to a visit or after a visit to get more information, and makes them actually more productive in the next visit because they've got a leg up. The deployment model side started years ago with binders. I've known so many people in my family and friends circle that have collected dutifully information about their loved ones or about themselves and put it in binders because it's the only way to actually feel confident that when you go into a specialist, especially in another community, or like having to go to the Lower Mainland, that you can have the information to present to them if they're missing it. But there's also this plethora, as I mentioned before, about the portals, which are really tethered solutions. And there's the one thing that the literature shows quite clearly is that the tethered solutions are the least likely to have benefit, and a provider tethered solution, like a portal that's connected to a provider's EMR, actually has been proven or shown in some studies to be a negative benefit. And that played out very clearly in Nova Scotia when, after millions of dollars of deploying a single solution across the province, it was collapsed, and providers and patients led the charge about this isn't going to work for us. And then there's the notion of interconnected systems. And this is an example of my logged in MyLinks system in the US that does this brilliantly through the interoperability standards that have been enabled there to coalesce information, as well as do things like even sharing a record with groups, like groups of people who may have had trouble with funding in getting in the course of getting a transplant. So the ideal future state, we'll talk about in a second, but the scope of function, and just a little bit more detail on this, is that there's a whole bunch of stuff that patients, to being the CEO of themselves and their health, can contemplate as benefits from a digital solution. Planning and managing their health, interacting and participating with the team, especially in their longitudinal primary care team, managing their own information in ways that are far better than that little book that the picture in the last slide, getting access to care and services, and improving their digital and health literacy at the same time. And meanwhile, marrying this up with what do providers need to avoid that provider resistance, that this will unleash the wrath or unleash a host of an avalanche of messages and phone calls, and maybe even people jumping off bridges when they see their abnormal results, which doesn't happen, by the way. Open Notes has slammed that case shut. This is just by way of, just to show how we really took a very formal approach, an enterprise architecture approach, to look at patient needs from their healthcare, wellness, information management, digital health literacy, the strategic and tactical operational components of all that. Won't go into the details here at this point because it's that's quite involved. But in terms of the functions that go beyond the sharing of the health record, improving communication, having asynchronous communication that's in line with their health record, as opposed to being out there with SMS and other third-party solutions where it's not coalescing and being part of the record, nor is it aggregating the information that you're getting and the messages that you're getting from your specialist office, from your primary care office, from your health authority, from your laboratory services. So that's in addition to improving the workflow that's often associated with those communications, like pre-visit questionnaires, online scheduling, avoiding the endless telephone tag that goes in with that. We can book a car on our trip to Europe online and think nothing of it, but it can take hours to get an appointment with a physician. And apropos to the presentation on cancer care and wellness and prevention, having reminders, can imagine having all the reminders in an electronic medical record, especially the primary care record, that they're shared seamlessly with the patient. And so that, and now it reduces the administrative burden of the provider from having to send out notifications about your PAP is due, your mammogram is due, and so on and so forth. And also to give proxy access to those loved ones across the country who are looking after their elderly parents or someone, rather than having to somehow photocopy that binder and send a copy. The safety aspects of this, from a military term of 4 or 5 eyes, there's evidence that with having patients being able to look at their problem lists and med lists and other things and contemplate that and actually find things that might be missing and inquire on the next visit. You know, I think I have these other problems that I don't see on my list. I'm mistaken. It's kind of a scenario. And also to be able to have the care plan and the clinical summary to allow patients to be better equipped in their follow-up care instructions. We know that there's lots of gaps there. So now, borrowing from the science, the transition science, spearheaded by people like Trish Irwin in Australia, we took an approach of taking all that information and sort of formulating a loose long-term vision, hopefully one that can become a shared vision, collaboratively through the Pentagram Partnership plus kind of a process, and backcast to our current state in iterative steps to say, oh, this is where we want to be. What are the things that we're going to have to do to get there? And so looking at that from the point of view of the entire health system and where the crosshatched areas here are where personal health records stand to touch, through the mainstay functions of health, the support functions, and all the drivers around it for better health outcomes, and take the interoperability opportunity to break away from that tethered approach, albeit having portals still. The Health Gateway is brilliant, but as an adjunct for those with more complex situations, to have an interoperable PHR. Now we're really aided and abetted by a number of different things that have emerged now in the broader environment, like this interoperability saves lives and data disarray documents that recently emerged that led to Bill C-72 that prohibits, when it's enacted, it prohibits data blocking, and the Pan-Canadian Health Data Framework. Now, just briefly to show you what this long-term vision might look like is that if we have a system that can across all systems do EMR to EMR communication, like there's your referral and there's your response back, but it's the same pathway, the same standards that goes to the PHR, the information can flow back, and that can be that asynchronous messaging or whatever you want, or sharing of pre-visit information. Being able to take a clinical summary and move it around to a health authority system, for a health authority system to be able to respond to that. Say a physician saying, hey, I noticed the summary might be missing something. And also to say, for distributions that are currently ubiquitous across the system, from health authorities to the EMR, like we've been doing with the clinical summary in the north, and also to the PHR, and from there to the gateway to share in our portal, provincial portal. So anyway, I won't go into the details about the findings so far, but mostly this relates to the holistic support of patient needs through an interoperable system, which is critical for the need for collaboration as we identify solutions and deploy them, so that we can allay anxiety, fear, and promote positive experience. And the bottom line here to take away is that we need the integration from across all sources, just as we do with our personal schedules, and that the PHR can be an integrator of holistic information and integrate workflows and across systems in many different ways. So that is all she wrote, as they say. Any questions in the last 30 seconds? Or 2 minutes, actually, sorry.
Thank you very much. Very interesting to see how this is going to work. I don't see any questions in the chat, and I don't see anything yet in the, oh, here's the Q&A popping up here. Anonymous attendee, will we be able to find this presentation or resources anywhere?
I believe this will be shared. Certainly, we've given permission to share through the normal channels of this forum.
Does that answer the question of the anonymous attendee? Hopefully it does.
Okay.
Alrighty, with any further ado, we're going to move on to Dr. Angela Laludi, who's going to talk about connectivity and technology in rural communities.
Hi, before getting started, can everyone see my slides?
Yes, they look great, Angela.
Fantastic. Also, I want to distinguish that I'm not a doctor. I'm a research assistant though. Well, hello everyone. I want to thank you all for being here. And my name is Angela, as I said, and I'll be presenting our research on the impacts of connectivity and technology on rural communities. But first, I would like to acknowledge that I'm zooming in from the unceded Syilx Okanagan territory. Sorry. There we go. The research I will be presenting today is a part of a larger project being conducted by the team of researchers at UBC Okanagan campus, where I've been a research assistant for the past year and a half, and funded by the inside grants from the Social Science and Humanities Research Council of Canada. Our multidisciplinary team, consisting of academics from nursing, social work, management, and computer science, is exploring digital readiness in rural BC communities at different stages of arrival to inform us of their experiences and strive to better support digital inclusion after access. So, why rural? Well, where people live matters to their health and healthcare. In recent years, many have suggested that internet access should become a human right due to the large impact it has on day-to-day life and the opportunities it creates for people and for their health and well-being. As I'm sure everyone here has used some sort of internet-connected device today, whether that's to access social media, check your email, or to attend this conference. So I think it's fair to say that the internet allows us to get free, instant, worldwide communication. It allows us to access shopping options like Amazon and grocery stores. It gives us ability to shop local through Facebook Marketplace and websites, and also allows us to access various services. In recent years, the Government of Canada has set a goal to connect all Canadian cities with faster broadband access by the year 2030, and specifically 2027 in BC. However, in 2023, only 62% of Canadians living in rural areas had access to internet connection with broadband speeds of at least 50 megabytes per second, or Mbps, for download, and 10 Mbps for upload. Meanwhile, 91.4% of urban Canadians have access to internet speeds that are at minimum of that. Furthermore, we have seen rapid growth in technology adoption post the COVID pandemic in rural and urban regions. Researchers argue that this growth is more positive than negative, as it allows people to work remotely, learn from home, access services, and shop online. However, negative outcomes include the inability for some individuals to access these resources because of furthering the digital divide. And also, as a small primer, the digital divide refers to the gap between individuals or communities that have access to modern information technology and those that do not. Thus, this divide can have a negative impact on economic opportunities, education, healthcare, and social inclusion. With that in mind, we conducted an online and paper survey in the fall of 2023 to gather information on rural adults' online activities, frequency of digital resource use, and the impacts of internet-connected technologies in rural communities under the context of connectivity. Importantly, we ensured that paper surveys were distributed to areas with little to low connectivity to ensure that we have a comprehensive representation of rural BC communities. Our final sample consisted of 461 rural adults. The average age was almost 56 years old, and the additional demographic information is displayed on the slide for your perusal. For the sake of time, I won't go over it, but for the main part, participants identified as female and white. Importantly, participants came from diverse regions within BC, mainly coming from interior and Vancouver Island regions. Participants were also asked to report their community's name, and the Statistics Canada Index of Remoteness was assigned based on the 2016 census subdivisions. The remoteness scores ranged from 0 to 1, with higher scores equaling more remote communities. After that, participants were organized within 4 categories. There's usually 5, but we only got 4. And we see that participants resided more in remote, less accessible, and very remote areas. With regards to connectivity and online access, we saw that about 84% of participants noted active use of digitally connected devices within their community. And upon further analysis, we saw that 44 of those had adequate or excellent connection, while 41% had reported having inadequate or poor connection to the internet, thus highlighting possible disparities between rural communities and the opportunities that are available to them. In an attempt to better understand rural adults' online activities, we also asked how frequently they partook in different online tasks. Response options included 1, never, and all the way to 8, once a day or more. And the table highlights the frequency of these tasks, going from most to least frequent. Interestingly, we noted that accessing social media, using streaming services, and using local information forums were amongst the most common activities, while accessing patient portals for healthcare, searching or applying for jobs were less frequent. However, this does make sense, such as you were not going to be applying for work or jobs every day, I guess, while you might reach out to your friends or want to check your email and stream and watch TV. Participants also noted various ways that technology has impacted their communities. Staying consistent with previous research I shared earlier, more sentiments are positive than negative, and noted that the COVID-19 pandemic was a large motivator to start using new technology. Most participants focused on being grateful for being able to access important resources and records for their health. Furthermore, they were also grateful for being able to stay connected and be updated on community news, events, and emergencies. Additionally, they felt relieved that they can do everyday tasks like apply for work or bank online. This is interesting, as if you remember from the last slide, online portals was not a frequent activity, but many noted that it was the most transformative tool for themselves and their communities. Importantly, some participants noted that online connected technology has been a lifesaver for people with physical disabilities or people who are of older age, since these factors make traveling a lot more hard to do. Additionally, negative sentiments focused on this new sense of social isolation, as it's affecting people's perception of their community. I imagine this is due to possibly people conducting their social communication through online means rather than in person. And on a similar note, some participants noted that their community has become more lazy or unproductive because they choose maybe to conduct their day-to-day business online as well. Lastly, in exploring the role of participant connectivity, we saw that there weren't many differences between those with and without high-speed broadband. And this is specifically true for most online activities except streaming, so Netflix. This is curious, but it can be explained by the fact that internet access has become an absolute necessity. So people have found ways to get access, and in fact, even those without faster broadband have some level of connectivity, and even lower speeds are able to access things like email and stream. Additionally, we saw that those with lower access reported feeling more frustrated with their connection, had fewer connected devices, rated their internet quality as lower, and felt more limited by it. In terms of considering the implications of rurality, we found that participants' rurality index was slightly related to connectivity, which again does make sense, as the more remote a community is, the less likely or more hard it will be to have wired connection. However, many participants noted that satellite internet options like Starlink have been a game changer in terms of getting connected. Also, we did reach some participants with no at-home internet access, and they have said that they've found creative ways to staying connected, either using mobile data or accessing public spaces like libraries. As this research was a part of a larger study primarily investigating digital readiness and connectivity, more detailed research is needed to further explore the impacts of digitally connected devices in communities and the experiences of rural adults to uncover ways to support those that are transitioning or have recently gained access to broadband. Additionally, more research may help us better understand how poor access is limiting and impacting communities. Although some participants reported having adequate connectivity, many were still struggling to utilize digital tools to their full capabilities due to their poor connection or possibly poor digital literacy, pointing to some knowledge gaps in rural communities. Our lab is currently conducting a systematic mixed studies review on digital health literacy training for technology to support older adults living with cardiovascular disease. And it hopes to identify gaps in our knowledge, propose future research, and inform future training programs. However, participants still noted more positive community changes, and they have found avenues to staying connected, highlighting the importance of digitally connected devices and online tools within the rural context. Thank you.
Thank you very much. Very interesting. Are there any questions or comments right now? So here's one for me, and the what proportion of people are not connected, and are they systemically different from people that are connected?
Well, from based on online activities, we can't really see, or we can see that they're not super different in terms of what they do online or what they hope to do. But we assume people that are more disconnected, I guess, reality has a big impact on that. And also some people note that they are not interested in getting connected, which I think is also impacting people's desire to, like, if you live in very rural communities, maybe you want to, when you don't want to be a part of the connected broadband and do that stuff. It's just some people face sentiments where they are almost forced to become connected because they're missing out on several opportunities which they would be allowed to access with their offline. So
does age have anything to do with it?
For some individuals, yes. Some participants note that they're getting older and they're having a hard time navigate this new ecosystem. So they sometimes kind of I don't even want to try attitude, which makes sense. I mean, I understand it can be very overwhelming to take everything in. So
is there a plan for reaching out to, because I have a feeling the people that are also older and more rural are going to have worse health outcomes no matter, going to have worse health outcomes as a baseline. So they're already vulnerable from that point of view. Just something to think about. I don't want to put you on the spot here too much because you've given a very good presentation already, but how do you reach out to people that are difficult to reach out to for this?
yeah, I know we made a lot of efforts to advertise through local means as well, through public libraries, and also kind of dispersing our survey like that, or also giving the option to have mail out surveys for communities. So that is how we're trying to target. But that is a great question. Yes, all those questions are amazing, and they are something to think about when conducting rural research.
Yeah, part of the reason I bring this up is our next, I don't want to give away too much from the next topic because I'm not sure what Dr. Cressman's going to be talking about, but I don't want to give away too much. But we're seeing definitely a pattern in people who are more comfortable with technology and people who aren't more comfortable with or less comfortable with technology. There's always going to be early adopters, then the mushy middle, and then people are very late or non-adopters. And I just don't want the non-adopters who are already probably behind, medically and perhaps socially, to be left behind either by another technology gap, which will push them even further down. So anyway, just my 0.02 cents there. Here's a question from Mary Catherine Williams. It's a comment, I guess. In our region, North Vancouver Island, we have some plans for both research and project activities to improve digital literacy for older adults here. It is much needed. That sounds like a really good strategy. Now, when you say something like some programs or some plans, maybe Dr. Williams could write some of these things out for the benefit of the rest of the audience, or maybe comment even online verbally or on Zoom verbally.
Do you want me to comment? It was my comment. So we're working with a researcher from UVic, Dr. Claudia Lai, and we have some funding already in place and some future funding that we've requested to do some research on using technology for older adults to access information and supports as they age, health and other issues. And then we've applied for a New Horizons grant for the coming year to do a digital literacy training project in our region. So they're kind of active plans, but we know it's a huge issue. And it's a matter of funding and volunteer resources and just kind of building that capacity in our already struggling communities. So, and then the Connected Coast piece, like we live in really remote areas. We do have a Connected Coast project trying to connect all of our rural communities across the island, but it's still in progress. So it's definitely an issue as well, just having connectivity. But thanks, it was really interesting information. Thank you.
A comment from Ms. Allison James. I wonder how a qualitative study would complement your survey to further understand gaps in needs.
Yeah, actually some of our findings towards the end about the health portals or like accessing events and news online are from open-ended. So they have really helped shed a light to like the quantitative, because there's only so much you can tell. So they have been super helpful, yes.
Excellent. Well, thank you very much. My pleasure to introduce Sonia Cressman. Conflict of interest here on my part. I've worked with Dr. Cressman for about 2 years as she evaluates the RTVS program.
Hi, thank you so much. Am I audible? Can everyone hear me?
You sound great.
Awesome, thank you. And the pleasure is absolutely mine. I am not a doctor, but I am very fortunate to work with fantastic doctors. I'm a health economist and evaluation lead at UBC Digital Emergency Medicine. I'll just share my screen. Hang on a second. Slideshow. And can I just check and make sure that you can see slides? All good?
Looks great.
Yep, perfect. Okay, so today I'm going to share some of the Learning Health System findings in our annual report of the Real-Time Virtual Support Network. I work at UBC Digital Emergency Medicine. I'm just going to acknowledge my mentor, Dr. Kendall Ho, and the team of evaluators that stand behind this work that I'm speaking on behalf of, as well as our partners at the Rural Coordination Centre of BC, First Nations Health Authority, and HealthLink BC. Before I begin, I want to acknowledge the Coast Salish territories cared for by the Musqueam, Squamish, and Tsleil-Waututh people that I am physically on today, and acknowledge that what the information I am sharing comes from a very westernized worldview. And one of the things I'm learning is that this needs to be balanced with other ways of knowing and doing. And I would like to just create space for that in our understanding of this work. So the RTVS Learning Health System is this partnership pentagram plus model of collaboration between organizations, and we do these rapid annual cycles of data to knowledge to practice. And every year it comes together in this annual report. You can see that the latest one here is available on the RCCBC website at that QR code on the right-hand side. And this will be our 4th cycle of learning in our 4th annual report for the RTVS program. The first one was really centered on establishing the network and learning about how a network of physician services can span across the province. The second was about how do we nurture this network and coordinate with each other and expand. The third, we started to home in on how can we demonstrate social accountability and improving access to service with evidence from the data. And this 4th cycle I'm going to share with you has gotten us there to a point where we can show that the network has an impact on shifting the distribution of access to physician services. So this is grounded in our evaluation framework that we use to inform the report. And our evaluation framework is centered on the quintuple aim. So health equity is at a major focus for RTVS, as well as provider and patient experience. And we hope to improve population health and have data to show that, and reduce the cost per capita of healthcare, which is central to the quintuple aim. This is a snapshot of our evaluation framework. Some of the indicators fall within these domains and are packaged as metrics in our evaluation framework that go into our report. So the top one is all about equity. It's the safety net in being able to ensure that population-wide people are having access to physician services. But the partnership is also motivated to show coordination of care. Culturally safe care is a huge part of RTVS, and they report on their success in this area. annually, and there has been some remarkable inter-partnership learning there, as well as relationships. And my favorite domain is the efficiency domain, where we're looking at balancing cost effectiveness with investments in improving equitable access to care. We also care about recruitment and retention, and then the ability to integrate within all aspects of the healthcare systems in BC. Our methods for evaluation are mixed, and I will talk to you about quantitative method from the HDP platform that Dr. Andrusiak introduced and explained so well earlier today. But we also include patient interviews in our annual report, start at the first time in our last learning cycle, and we'll do that again this year, and working with program administrators to include qualitative data as our source of information for these reports. And the reports are generated with the partners. Early on, everyone agrees and signs off on the report and is a part of the learning. Sorry, just the next slide. So the real-time virtual support system is a network of 9 pathways. It's actually 10 this year, but it has includes peer-to-peer pathways and client-facing. The top 3 pathways have been around. The top 3 have been since 2020, around the time of the pandemic. HIDE was implemented at the start of the pandemic, and First Nations Virtual Doctor of the Day. And some of the programs were pandemic responsive, and I'll talk to you a little bit more about that. The bottom 4 pathways are peer-to-peer support networks, so physicians helping healthcare providers with services through the peer-to-peer pathways, and I'll explain each one in detail. And then the middle green one is a 3-way conversation support network called the C2C program, where family physicians and specialists and patients have 3-way conversations. So those are all included in our annual evaluation. I'll start with talking about how these 3 pathways. I'm not going to be able to talk about Rudi MRP because it started in September 2022, and we don't yet have enough data to be reporting on the distribution of access, but we will in the future. So that's a new pathway, the Rudi MRP pathway, but the other 3 ones I'll go into in detail. And the metric I'm going to use to report on the distribution of access lives within the HDP data platform. It's called the Canadian Index of Multiple Deprivation. It's a socioeconomic status indicator comprised of 4 different dimensions. They're listed here: the ethnocultural composition dimension, which reflects socioeconomic differences in immigration primarily. Also, there's housing density, habitation density in the number of persons per room, and that type of ethnocultural contributors to this domain. The situational vulnerability domain is interesting because it's driven by income, education, and it also reflects Indigenous status. And these are area-based incomes from census data. So they can serve as a proxy of what patients might report if we had data on everybody from self-report. The economic dependency domain is primarily driven by labor force participation, and age is a big component of that. And the residential instability speaks about neighborhood density and habitational status. So they measure different aspects of socioeconomic status and can be used to evaluate the program because it lives in the HDP data. So what we can do is we can create these slopes that you see here. This is a distribution of the data for people who use the Rudi pathway. So these are all of the rural urgent doctor in AIDS encounters mapped per patient and across each of those dimensions of the CIMD. I'll walk you through this one, but first I'll introduce the Rudi pathway for people that don't know it. It is one of the peer-to-peer pathway lines where an urgent doctor, where a community in a rural area may have an urgent health concern, and 24 hours, 7 days a day, 7 days a week, you can call this number and speak with an urgent care doctor who has experience with emergency and rural health. And it's been around since the pandemic, and we have just over 10,000 calls per year. So it's a good data supporting these metrics I'm going to show you for Rudy. And it contribute, so the calls to Rudy are contributing to these data. What you're looking at here are different 4 panels representing each of those CIMD domains. And if we center our eyes up onto the top left panel, you'll see a series of 5 histogram bars, and then the slope of that line connecting the means of those bars. And those are quintiles ranging from the most advantaged to the least advantaged. And so on the right-hand side, you can see that the least advantaged quintile, the economic dependency, is served slightly higher than the most advantaged. And what you see in dotted lines is the curve for the overall BC population, and the solid lines are from the data of people who use Rudy. So what the difference, if I can, oh good, I can annotate, what I can just draw it on the graph here. You can see this is the shift I'm talking about here. When you look at the most disadvantaged quintile, and you can see that the service reaches those people more, that's when you see a shift in the distribution of access. So we see that for the economic dependency quintile in this quadrant. And what we don't see is a shift for people with advantages in their ethnocultural composition. And that makes sense because of the demographic makeup of people who need to use Rudy. It's generally rural populations with a lower representation of people with immigration differences and different languages. And so that makes sense for the demographic, that the shift is actually more towards people with advantages in the ethnocultural composition domain of the CIMD. When we go down to the residential instability domain, you can see that again, the housing is more towards people with advantages. So we see in rural areas, you've got more room and less dense housing. So that makes a lot of sense for Rudy. But the real shift in distribution is that situational vulnerability domain of the CIMD for Rudy, where you're really seeing a strong shift compared to the BC population norm for people with the most disadvantages in their education, income, and Indigenous status. So that's one of our very strong findings for our TVF, supporting this notion that we're improving the distribution of access. And one day we'd love to be able to use this in economic evaluation to compare to other competing policy alternatives or to improve the service. So I'm going to move on to the next pathway. This is a pediatric care line. So it's called Charlie, for the Child Health Advice in Real Time Electronically, serving families in rural and remote areas with pediatric care needs. And this pathway has been around since the pandemic, but there are fewer encounters than we see for Rudy, at about 3,000 per year. So we're a bit limited by our data, and also some of the reporting for Charlie comes in at different times from within the HDP data extraction. So you don't see any green bars in the ethnocultural composition scale because that data was not available. But we do have a full data set for 23-24 for Charlie participants, and have enough people to report on that as well. So we can see a similar slightly less shift in the economic dependency distribution of access here. And that is making a lot of sense because children are generally outside of that age group of being able to work. So that's not as surprising. The ethnocultural composition, again, ethnocultural composition isn't necessarily something that we look for in a rural population. So that's a different direction. Situational vulnerability mirrored what Rudy did as well, really demonstrating that strong shift for reaching individuals with disadvantages in income, education, and their Indigenous status. And a similar finding for the final peer pathway that I'm going to report on, the MABLE, Maternities and Babies Access Line, providing maternity care, even less data. So we've got around 1,000 encounters for this pathway, but really showing the same trends in the situational vulnerability and economic dependency index shifts. So I'm going to move on towards the patient-facing pathways and give you the results for the First Nations Virtual Doctor of the Day program designed to provide culturally safe primary care to First Nations clients and their families, and the First Nations Virtual Substance Use and Psychiatry program to provide virtual psychiatry and addiction services. So we did see shifts, similar patterns in the First Nations Virtual Doctor of the Day, particularly in the situational vulnerability domain. Very strong shift upwards towards most disadvantaged, reflecting the Indigenous status and situational vulnerability, and ethnocultural composition, not one of the priority targets for this line. We saw another shift in situational vulnerability, and also residential instability seems to be having a bit of a movement here over the years with the virtual substance use and psychiatry service line. And so again, this pathway also demonstrates that shift towards people with the disadvantages in their situational vulnerability. I'll finish off by speaking to Dr. Schiermeier's favorite pathway, the Heidi pathway, and we've also got another patient-facing pathway designed to deliver therapy prescriptions. It's called Katie, and I'll introduce those in a sec. We'll start with Heidi. This is our largest call volume. This pathway has the largest call volume of all the RTVS pathways at 50,000 encounters approximately per year. We have good, solid data, and it's very aggregated. So it's behaving very similar to the population. The HealthLink BC Emergency Eye Doctor and Assistance Program offers information and advice, and it's embedded within the 811 call center, available 24 hours, 7 days a week to anybody in the province. And upon pre-screening and triage, you can be referred to a Heidi physician and C1 and 50,000 people per year do. And what the shifts that we see are very closely aligned with the dotted lines here. So similar to what happens in the population, perhaps reaching a bit of a shift in the residential instability domain, which is novel among the RTVS pathways and would reflect more densely populated communities and lower income, apartments and high density housing. Whereas the ethnocultural composition scale, what's interesting is with such big numbers, what we can do is we can break apart the data and do a disaggregation by age, sex, and region. And for age, we saw diverging effects across the ethnocultural composition scale. And I think our previous presenter kind of alluded to this maybe being an issue with internet access, in that what we saw was that people with disadvantages in their ethnocultural compositions domain of the CIMD who were older, Heidi was less able to reach those groups. Whereas we saw a real strong shift for people that were younger with ethnocultural disadvantages. So a real strong diverging effect there that kind of comes across as a flat line in the aggregated data. It tells us two things. It tells us, one, where we're doing really well is reaching these immigration, newcomer, and different language speaking populations that are younger. And that's going well, whereas the older population, that would be an area where we want to learn more how we can tailor the program and start reaching that population with a priority. So that's where our qualitative interviews are focused this year, and you will see those results in next year's annual Learning Health Systems report based on this demographic here, where we saw that the Heidi wasn't reaching the population as high as the other age demographic. And I'll finish with Katie. Katie, oops. Sorry, my hand.
Dr. Cressman, we're
We're over time.
9 minutes over your talk. We've let this slide here because it's really, really interesting stuff here, but there's a number of the question period's gone and we're already 4 minutes into the next presenters. So as much as I've been debating for the past 5 minutes with a step in or not, but I mean, your presentation is really, really important. And I know it makes it difficult because we are co-researchers on this, but I feel terrible about doing this. But
do it. No,
yeah, if there's any questions, if we can put it in the Q&A, that would be great. Thank you so much. This is actually incredibly important stuff. So that's why I'm like, hey, I want to hear about this as well. But last, we're going to have the presenters are going to be Doctors Vanya Tjandra and Emily Thompson. So thank you.
So unfortunately, we haven't seen Vanya join, so I'm not sure, Emily, if you'll be presenting solo today.
Oh, sorry, I thought she was on the call.
I see. Yeah. Vanya, you are on as an attendee. We will pull you over to a presenter. One moment. Or it looks like Jason's done, so thank you.
Good afternoon, everyone. Over the next 10 minutes, we'll briefly walk you through our scoping review study, where we synthesize partnership strategies and principles from virtual health innovation research conducted within rural, remote, and Indigenous communities. Before we start our presentations, we want to respectfully acknowledge that from the beginning until now, our work has been conducted in the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. Personally, I'm utterly grateful to be able to play and then continually work and learn in this beautiful land. Research partnerships where academic researchers and non-academic partners work together collaboratively within the research process offer a promising approach to improving the uptake of research and maximizing impact by developing a more meaningful and relevant solutions or innovation. These non-academic partners can include policymakers, healthcare providers, patients, and community members. And some of the commonly encountered approaches to partnerships include patient and public involvement, community-based research partnerships, and integrated knowledge translation. Virtual Health Innovation Project in rural, remote, and Indigenous community are an area that can particularly benefit from research partnerships, as they help to address the unique inequities in these areas. By directly involving non-academic partners into the research partnerships, the innovation can better meet the diverse needs of community and considers factors like limited resources. Virtual health innovation on its own is defined as tools and platforms aimed at improving delivery, access, or quality of healthcare services. Examples included telehealth, digital health and training resources, mobile-based apps, and incorporating community perspective in the design, implementations, and evaluations of these innovations is key to ensure that innovations are meaningful and useful for the community that they serve. However, building and sustaining partnerships with rural, remote, and Indigenous communities can be challenging. As of now, there is limited evidence-based guidance and support available to support virtual health innovation partnership. So our current research objective is all about exploring the how of research partnerships, focusing on what drive effective collaborations. Our scoping review aimed to synthesize the Karen standards and partnership processes, such as principles and strategies in the context of virtual health research with rural, remote, and indigenous communities. And in understanding research partnerships, we're anchoring our study in the previously established guiding framework, which describe 4 main domains of partnerships. And our current research study primarily focused on the 2 main domains, which is partnership principles and strategies. Principle is defined as fundamental value, norms, or rules that reflect what is considered positive and desirable. It is more abstract and broad in nature, but in contrast, a strategy is more concrete. It serves as a means to implement these principles within the research process and is defined as observable actions specifically designed to achieve a particular outcome. So to better illustrate this, an example of a foundational principles is the dedications to valuing co-productions of knowledge, where researchers commit to ensure equal and active participations of non-academic partners throughout the research process, whereas the concrete strategies used to implement these principles into actions include directly involving non-academic partners in identifying and refining research questions and in the design of the innovation.
Our methodology included a scoping review, title and abstract screening, and full text screening. The scoping review was conducted from January 2020 to May 2024, searching 5 health databases. The full text screening inclusion and exclusion criteria consisted of a target population, so the article included a target population of individuals living in rural and remote communities. The article meets our definition of a health research partnership. The article relates to the development, evaluation, or implementation of a virtual health innovation that aims to improve healthcare and services in rural, remote, and indigenous communities. And the article describes a clear example of a principle or strategy, or at least one example of an outcome or impact of the collaborative research activity. 4 team members independently screened the title and abstracts in full text basis. Data extraction was completed on papers that met our inclusion and exclusion criteria. It included general information about the paper, context, innovation, research partnership principles, strategies, and outcomes and impacts. The extracted principles and strategies and outcomes and impacts were analyzed using directed qualitative analysis and synthesized into overarching principles. We identified and screened the abstracts of over 6,000 sources and ended up including and extracting data from 62 full-text articles.
So moving to the result, our scoping review include articles from a wide range of countries, such as Canada, Australia, United States of America, Europe, New Zealand, Africa, and Asia. This diversity might reflect an increasing global interest in research partnerships and also contribute to the variety of partnership approaches used. And an interesting result among the paper we identified, nearly half of them involve partnership with Indigenous partners, such as Indigenous community members, local advisory board, and Indigenous elders. As for principles, we identify a total of 145 unique principles, which are then organized and synthesized into 18 overarching principles. And among these 18 overarching principles, the most commonly described principles are relating to relationship building, shared decision-making, and co-productions of knowledge.
82 unique strategies were synthesized into 12 overarching strategies. There are engagement strategies that are specific to the research process, and this includes planning, conducting, and dissemination. All other strategies can be applied throughout at any point in the research process. So this includes communication activities, which is verbal, written, visual methods, development of norms, rules, and expectations, and fostering the collaboration and communication process. Other strategies include partnership initiation and representation, as well as education and training. In summary, our scoping review identified a variety of principles and strategies from virtual health research partnerships. Our review identified gaps in lacks of consistent and detailed reporting and partnership processes. Something interesting we identified was that Indigenous research partnerships and principles often reported and emphasized unique frameworks, tools, and guidances used. These findings from our scoping review can be used to inform the development of tools and resources for research partnerships in rural, remote, and Indigenous communities.
Moving to the next step, first, as part of our study, we're also going to identify and synthesize outcome of research partnerships. Specifically, we would extract outcome and impacts from formal evaluation paper to better understand the why of research partnerships, really getting to understand its impact and value within virtual health innovations in rural, remote, and Indigenous community. We're also going to use the finding from our study to conduct a follow-up study where we will identify partnership champions and invite them for interview to further explore their perceptions and experience in conducting research partnerships. So as for our take-home messages, understanding the process underlying research partnership is key to support more effective collaborations between researchers and non-academic partners. And hence, our scoping review provides the initial steps toward increasing our knowledge of research partnerships and improving evidence-based guidance that can support virtual health research within rural, remote, and Indigenous community. Thank you for listening to our presentations. For more information, please reach out to the contact information listed here. Thank you.
Excellent. Thank you. Thank you very much. Are there any, well, there's some applause from Dr. Cressman. Thank you very much, Sonia. Is there any questions at all or anything in the Q&A? This is important foundational stuff. Well, in that case, I think that's going to conclude the late morning session of presentations, the real good cross-section of some amazing projects going on in British Columbia. I think the authors and presenters can be, and researchers can be very, very proud of what they've done. There's some project here that will definitely benefit many, many British Columbians, including ones that aren't often, will get to be involved in studies or research. So hopefully this fulfills the quintuple aim that Dr. Cressman talked about. I would ask if Jason, or this can be put in the chat, Jason or Tracy, if someone is really interested in getting their hands on a presentation, can those be sent to somebody, the author or the presenter willing?
Great question, Frank. All the presentations have been recorded and will be available on the BC Rural Health Research Exchange webpage in about a week's time. Also, if you have a keen interest in something specific, please feel free to reach out to me and I'd be happy to connect you with them and make sure that they're happy with that as well. So please reach out to Jason or myself. If you would like to be connected directly. Otherwise, stay tuned for the recordings. Thank you to Frank for working through this with us again this year. We're happy to have you back every year, as well as Brenna. Thank you to Jason. Thank you to all the presenters. I'll stay on the line if anyone has any questions, and have a wonderful day.
Thanks, everyone.
Jason still on here?
I certainly am.
Still on, Frank.
Okay, who?
One
Okay.
sec here. Well,
Who's the participants here? Thought we'd debrief here